Madam Chair, we're live.
Very good. Good morning, everybody out there in viewer land and members on the Zoom committee. Welcome to yet another Zoom meeting of the Joint Labor, Health, and Social Services Committee for the state of Wyoming. Welcome to all. Someday we will be back again in person. We look forward to that. I'm sure all of us, we are probably getting a little tired of seeing each other in little tiny rectangles. Will we have some from LSO? Please take the roll.
Senator Baldwin.
Here.
Senator Bouchard.
Here.
Senator Pappas.
Here.
Senator Schuler.
Here.
Representative Barlow.
Here.
Representative Clem.
Here.
Representative Dayton Selman.
Here.
Representative Hallinan.
Here.
Representative Roscoe.
Here.
Representative Stibar.
Here.
Representative Sweeney.
Here.
Representative Yin.
Here.
Co-Chairman Scott.
Here.
Co-Chairman Wilson.
Here.
We have a quorum.
Very good. LSO, do you have any particular last minute remarks to us before we plunge into the agenda?
No, ma'am.
Very good. Then the first item on our agenda today is reconsideration of the COVID-19 legislation that we passed out of committee in May, not for purposes to reconsider in the sense of changing our minds, I hope, but rather that when we drafted these bills, there was some language in them that was pertinent to a proposed special session. And co-chairman Scott and I looked at them and said, there are a few tweaks that we want to make to the language just to make them relevant for what will probably be just the general session and not any intervening special session. Although I think we have a few possible amendments to the community health center that we will consider. So the first bill is titled now 21 LSO 0061. This is the Insurance, Mental Health, and Substance Use Parity Bill. And we wanted to hopefully hear a motion to run this in the general session. And then I have the pertinent amendment to bring. Co-Chairman Scott, and you're muted.
Madam Chairman, I'll move that we introduce it as a committee bill in the general session.
Is there a second?
Second.
Seconded by Baldwin. Okay, then if there's any discussion, which I have a discussion, but we will certainly hear any further discussion on that and take comment as normal. But on page 4 of your bill, line 3, we originally said that the act would apply to all policies on or after January 1, 2021, which obviously, if we have it in the general session, won't be pertinent. I'm going to offer one amendment. I know there's another possible. I'll just offer the one for discussion and I guess explain them both. The first probable amendment would be to just change the year to 2022. And that way, whatever happens in the general session and then through the summer, all the insurers have time for their policies starting January 1. So do I have a second for that amendment? Seconded by Senator Schuler. I will, and I'll let people go on to discussion, but I will just say that there was also discussion, what Senator Scott and I talked yesterday, that we perhaps would prefer April 1, 2021, and the purpose of that would be if there are, say, school district policies or something like that, that impact people. Maybe their start date might be August 15th or, you know, some such date. So that's, but for now, we'll talk about the January 1 amendment. Senator Scott.
Madam Chairman, I would urge us to go to April 1st of 2021. That would have the advantage of picking up not only the example you gave of school district policies, perhaps, but small group policies renewed throughout the year, are concentrated in the fall the way the ones through the Obamacare exchange are. And this is a relatively minor change. I think a number of the insurers may already be doing it. So I think it's better to get it started, and that way it'll also catch in the fall when all the policies through the Obamacare exchange renew. It will affect all of them instead of having to wait a year then. So I think that this particular parity is a good idea, and let's go ahead and get it started. And April 1st is a convenient date after we know that action on the bill will have been completed if it's going to pass at all.
Okay, so fair enough. I'll take any other comments on the Jan 2022 date. If people vote no, then I assume that we will have a proposed alternate amendment of April 1. So is there any more comments on the 2022, because we've got this amendment on the table?
Madam Chairman.
Chairman Scott.
If it's all right with you, what I'd like to do is move to amend the amendment that's on the table to read April 1, 2021. We know we have to change the date to fit a general session. So I'm just proposing a different date, and I think the easiest way to do is just to propose to amend your amendment.
Good thought. Senator Schuler, I think you were the second. Is that okay with you?
Yes,
All right.
a friendly
All right.
amendment.
Any further discussion on the amended amendment? I don't see any. All right, then all of those. So remember, we will just, I don't seem to have my little blue hands and whatnot stuck up yet. For now, we'll just go with the hands in front of your face. If you're in favor of amending the bill to April 1, put your vote aye. I see 13. Is there a no? Representative Barlow is a no. That amendment passes. Okay, any further discussion on the bill? I think do we have any public let's see, I guess I didn't do this right. It's only been a month since I ran a committee and I've kind of botched it up already. Was there any public comment on this bill before we vote on the bill?
Yes, ma'am. You have two individuals who have signed up for public comment on this bill.
All
Ms.
right,
Wendy Karen and Andy Somerville. We'll
let them in.
them at this time.
I'm going to call on Wendy Curran first.
Good morning.
Hi, Wendy.
Good morning. Madam Chairman, members of the committee, I'm Wendy Curran with Blue Cross Blue Shield of Wyoming, and I appreciate the opportunity to visit with you about this bill again. Can you hear me?
Oh, I can, and I just want to say I apologize for voting on the amendment before I called on you for public comment. I think, there's some downsides to having a committee meeting starting at 8:30 on Monday morning. Not the swiftest in the door. So go ahead, Wendy. I can hear you fine. Go ahead. Is there a lag? Can you hear me? Wendy, I think we hear sounds from your mic, but I'm not hearing you.
I can,
Oh, there you are. Or it's lagged or something.
let's try this. Am I on?
Yep, that's good.
All right. I appreciate the chance to visit with you about this legislation again. We support the expansion of telemedicine to, okay. One moment.
It's a good thing we're not testing for aphasia by telemedicine of Wendy, or we might really under.
Madam,
So, Representative Clem, were you? You've muted yourself, Representative Clem.
sorry. Thank you. It might be worth noting just for those who do give public comment to turn off their YouTube video because that is going to have a significant lag. So
Good point.
Thank you.
Good reminder. Okay. Wendy, are you back with us?
Yes, one moment, please. Thank you. Now are we on the same wavelength?
We can hear you anyway. I don't know about the wavelength.
All right,
but-
thank you very much. We support the expansion of telehealth audio and audiovisual and have found that to be very helpful during this recent pandemic time in making sure that members get care, that doctors can do things conveniently. And we're very much in support of this. We have always embraced telemedicine as the most effective way to give care. And we support this bill. We do, however, have one concern with a very specific language on page 3 in 3 little I. I believe that directs insurance companies to make sure that they pay the same for audio only services as they would for an in-person service. And this is where it starts to get a little complicated. A reimbursement and value of care procedures are defined by the federal government and the AMA through the CPT code. And those codes take into consideration the complexity of the care, the time that is needed, the practice expense to come up with a value for how that particular delivery of care should be coded, reimbursed, considered. And in determining those, I think there has been definition by CMS that there is more value to the patient, to the care, in a module that includes a visual component. And that is to say that the codes that are set up for how a provider bills reflect that. And face-to-face and audio-visual are determined to be very much the same. Audio only loses a component and therefore has a different set of codes that say if you are providing audio only care, that it's still valuable, it's still very helpful, but it does not provide the same technical components as does an audiovisual visit. Our concern is that this particular segment says we will reimburse for audio only at the same level as we do for an in-person, in-office or visual call. And that I think is problematic for us. That means that we would be out of sync with the way CMS is using this service, audio only. We would be out of sync with the way that Medicaid uses it. Our providers would, in fact, have to use a different set of codes to code for this. It's such a strange technicality to bring to this bill, and I apologize for that. I have worked to try and come up with language that somehow would clarify that. And I think we don't want to, we support the bill. We simply want to point out that there would be difficulty based on simply the way the system and the CPT codes are set up for us to reimburse an audio only visit exactly the same as an in-person visit. We can do that. It will be a mandate. It will put us out of the usual system, which has been set up to design to value care and pay for it. What we'd like it to say is maybe something along the lines that the reimbursement shall not be less than the procedure codes defined by this. And see, this is where I get into difficulty. I'm not exactly sure how to say that without making it very difficult. Our problem is that we would not, under normal circumstances, pay the same for an audio only visit, whether that was done by a behavioral health specialist or whether it was done by a family practice or a nurse practitioner. The reimbursement would be higher. The coding would be different for a face-to-face or in-person visit than it would be for audio only. So that's the problem. If we could tweak that one line in that one section, we support the bill and certainly don't want to do anything that's harmful. We just do want this to fit in with the current technology and the current terminology for how we do this.
So Wendy, looking at page 3, if we were to leave paragraph 1 as it is, that you can't deny coverage for audio or audiovisual. Paragraph 2, that you can't charge a different co-insurance for audio or audiovisual. But then in paragraph 3, say that you cannot reduce any payment to a healthcare provider using remote audiovisual to an amount that is less than the in-person, thus deleting on the end of 15 audio only, which would basically let you reduce the payment, pay less for audio only, but not audio visual. If we just, if we were to remove those 2 words, does that address your problem?
Madam Chairman, thank you. I believe it does. We would, as we have always done, be paying the same for audiovisual telemedicine as we do for in-person procedures, but it does give us the ability then to just pay the audio only portion in compliance in the same as we do for everyone.
Okay, well, I'm not saying that we'll do that necessarily, but I'm just clarifying. Okay, any questions for Ms. Curran? Representative Barlow. You're on mute still.
Thank you, Madam Chairman. Mrs. Kern, I want to be clear. All audio, what I understand you're testifying to is all remote audio-visual delivery systems are reimbursed the same as they would be if they were in person. If that's my understanding, fine. What I want to know is there are nuances to that, i.e. shorter sessions that may be 15 minutes or 10 minutes or 2 minutes that would be audio-visual, whereas in office they are in different increments, if that makes sense. Are there nuances between the two, audio-visual and in person? Thank you.
Ms. Curran.
Madam Chairman, Representative Barlow, there are nuances, and that speaks directly to the audio only portion. Audio only is determined by the length of the call, the number of minutes that are represented, whether you're a physician calling a patient or whether you're a psychologist paying or a therapist calling a patient. Those are coded by increments of time. For the other audio, or for the audio visual, those are similarly coded differently depending on the type of call it is. So that might be an E&M code that would say this is a easy, it might be simple. But the technicalities come in audio being slightly different than the other two. I would clarify that Blue Cross Blue Shield of Wyoming pays the same for audio visual visits as we do for in-person visits. I don't believe that that is the industry standard, and I'm not sure that all companies do.
Thank you.
Okay, any further questions for Ms. Curran? Okay, thank you.
Thank you.
Ms. Somerville.
Good morning, Madam Chairman. Just have a couple of quick comments. I'm going to step slightly outside my comfort zone in the insurance world because I'm certainly not an expert in insurance coding and want to defer to Ms. Curran on the technicalities of it. But I just wanted to mention to the committee in terms of comparing audio visual versus telephone only in the behavioral health world, that has become a staple toolbox. The providers always want to use audiovisual whenever we can, but especially in some of our rural areas or for clients that may not be as familiar with technology or may not have access to a computer, sometimes that audiovisual connection is just not possible. But we want to reach them however we can reach them. So if that's by telephone only, then that's what the providers are going to do. But what I wanted to mention is that the cost differential is just really not there between whether you're seeing them in an in-person setting, audio-visual, or telephone only. Your costs and your fixed costs still remain the same, and most of that is your providers or your clinician's salary. So I'd be happy to work with Ms. Curran to see if we can come up with a solution prior to session, but I would encourage you guys just to consider that, and for behavioral health, that telephone only is a pretty important tool in the toolbox still. And I'd stand with any questions.
Questions for Ms. Somerville? Okay, thank you. Okay. Committee, further discussion on the bill. Senator Bouchard.
Thank you, Madam Chair. I am concerned that we have a parity bill and we're not. I mean, the world has changed. I saw, you know, we've got Medicaid coverage that is doing audio only, and they're reimbursing. I'm just really concerned that if we do something here, we're not going to get it right. So I want to make sure we get it right before this bill becomes prime time. Thank you.
So, Senator Bouchard, if I can just understand, are you saying you would rather not bring the bill than have it mistaken, or are you saying you'd rather go forward as it is and get an amendment correct in session committee? What was your suggestion there?
Well, Madam Chair, thank you. I just want to, I'm okay going forward. I just want to make sure we get this part right. And if we don't, we can stop it later. I mean, but we want to make sure we dial in and get this right. It looks like like I said, I just did a quick look at what Medicaid was doing. If they're doing it, we should be able to figure out how to do this. And if that takes some work on the insurance company side, they're going to have to get their pencil sharp, and they're going to have to adjust as well, because I think there are technology concerns. I mean, we've got some people that get technology very well, and we have other people that don't, and we shouldn't have those people miss out on getting the care they need. We don't know what's coming, where we're going with this. I mean, who knows? I mean, I don't trust that we'll get a lot of other things right with COVID. So I think that we could see another term of situations where they won't be able to get into an office, you know, in coming seasons. So anyway, that's my concern. I don't want to. This is not something that we should take lightly with audio.
Very good. More questions. Let's see. More discussion. Co-Chairman Scott.
Yeah,
Madam Chairman, and I want to ask a question back to Ms. Curran. Was I right in understanding her testimony is that Medicare uses a different CPT code for audio than it does for in-person or audio visual.
Ms. Curran?
Madam Chairman, Senator Scott, I believe that is correct. And I say this because the codes for audio only, some were put into effect this summer at the beginning of COVID. And I know that those codes for audio only by timed minutes are the standard. Most healthcare payers, insurers, providers use the standardized CPT coding system, which determines the value and the differences between procedures. If Medicaid is using something different, I'm not certain, but that then again would be codes that they would be determining themselves.
Okay, Representative Clem.
Thank you, Madam Chairman. So I want to understand this a little bit more, and perhaps we can get testimony from either mental health providers or the insurance industry. But to me, it seems that there would be a difference as far as the quality of care with audio only versus even audio visual, or certainly in person. Particularly when we're talking about mental health things. I mean, if it's, so for instance, I can just, speaking to my own experience, not as a mental health provider by any means, but as a pastor, not too long ago was dealing with an individual who was struggling with substances. And it's hard to tell whether a person is, it can be hard to tell whether a person is using or under the influence perhaps of some kind of substance just on the phone. And so I don't want to discourage audio only. I'm just concerned that it's not the same quality as even audio visual or in person. And therefore the question is, should it be paying the same exact amount for that other type of quality of care? So that's where I struggle. I lean more towards a reduced payment for audio only. It may be more efficient in some cases, but I'm not sure overall it has the same type of quality. So perhaps if we could hear some testimony on that, that would be appreciated. Thank you.
More questions before I call back on the testifiers again, the witnesses. Was there any more questions that we can kind of group together? Okay, Ms. Curran, Representative Barlow.
Madam Chairman, is the insurance department available?
I don't know. LSO, do we have any insurance department people?
Ma'am, at the moment, we don't have anyone. Would you like us to try and contact them, or?
Representative Barlow, do you have a specific question we might be able to extract from them?
Well,
Sorry.
Madam Chairman, I guess, thank you, Madam Chairman. So the added language was from 2018, 17. Representative Dayton brought the language for the parity that this is actually building upon. So I guess what I wanted to know was what has been the effect of that from the insurance department's perspective, and how implementation, how has that been, so that we can see how that's been, so I can understand better how these particular changes might impact that. So it's more of a background from how we got here. Now we're extending it further or being more specific. That's what I was trying to get to, but we don't have to do it now. We can do it at the session when that time comes. Thank you, Madam Chairman.
Okay, yeah, if they're not on, it might be kind of hard to extract that information from them on the spur of the moment. Ms. Curran.
Madam Chairman, I would respond to Representative Clem's comments, and that is precisely why these services are different. We have been doing some informal polling of providers this summer as we talk about what changes move forward from the COVID pandemic allowances to more permanence. And we are not saying that audio only is not critically important, but what we have heard from providers, both behavioral health providers and from our own Physician Clinical Quality Advisory Committee, is that the preference would be to have a visual component. And if that is not possible, then yes, audio is helpful, may save lives, may avoid hospitalization, but it is a different level of quality of ability to understand what the patient is. And I think that forms the basis of a differential payment for audio only.
Ms. Somerville, did you have any to add on this?
Sure. Thank you, Madam Chairman. And what I would add is that I think we're going to have a lot more information about what's effective and what's not effective in audio and audio visual as studies that I'm sure everybody is aware of are ongoing. We're starting to get more feedback from providers. In general, there's a lot of studies that do support audio and audio visual as an appropriate method to provide care. And I think if we all had a preference, it would be for audio visual as much as possible. But frankly, we just don't have the infrastructure right now in Wyoming to make that possible, whether it's a lack of broadband connection or Wi-Fi, or frankly, for our community mental health centers who are seeing some of the poorest members of our communities, they don't have access to necessarily a tablet or a computer. And we're working to improve that, but we're just not quite there yet. And then on the provider side, I would tell you again, I'm sure they would all prefer to see people via telehealth with audiovisual or in person. But if they're working with a client over audio only, they're going to use every skill set they have to assess for any misinformation due to visual cues and things along those lines. So I'm not sure that we have the correct answer for whether it's really an acceptable alternative, Representative Clem, but I hope that information helps a little bit.
Okay. Oh, Senator Scott.
Madam Chairman, are you ready for an amendment?
Sure.
Okay. Madam Chairman, I would move on page 3, line 15, delete the words remote audio or, so it would read using audio visual delivery systems. Second, I'll explain exactly what I'm up to and why.
I'll second it.
Seconded by Clem.
Madam Chairman, this was your suggestion for solving the problem, and the effect of it is to mandate for the audio visual the equal payments and allow, and then it's silent on what the payment is for audio. Covering audio is required by the earlier subsection, but the complete equality is not required if you leave them out of this. And what I think will happen is that the insurers will go with, as they usually do, with the industry standards, which is being set by Medicare and Medicaid, using those same codes, because it'll be administratively a lot simpler. And I think we'll be safe doing that. It won't be perfect. Nothing we ever do in this world is perfect, I think. But this will give them the flexibility to handle it administratively. And if there can be some better language to define that, we could consider that during session. But by being silent on the absolute equality of payment after mandating that it is covered, will give them the flexibility to deal with the issue administratively. And I think that's probably the best way to go at this point.
In the Co-Chairman Scott, I do have a possible amendment if this is okay with your amendment. I would leave the word remote in the sentence so that it's remote audio visual. I mean, I can't really hypothesize what sort of on-site audio visual we might be doing, but we put the remote in there as another way of talking about telehealth. So I think if we just delete the audio, or if that's okay with you and the co-chairman, that way we won't accidentally somehow leave out remote audiovisual?
Madam Chairman, that's fine with me.
Is that all right with the, okay. All right, so if there's no other discussion, and committee, here's what I'll say about this. I think that there's probably a few more issues that we want to wrestle with. I mean, I think both sides that have been brought up have validity to further discuss, find out a little bit more what the Medicaid approach is, find out maybe per Representative Barlow's discussion from the insurance department, if we can get a few more tweaks. I'm not sure that there's much more value to spending a lot longer, in this interim committee wrestling with that. I would say whether whether the amendment passes or fails, I would propose that we carry the bill forward in session, and then we may, whichever, if we amend out audio or leave it in, I'm sure it will be revisited in committee hearing during session, at which point we'll have several more months of experience and can get some more testimony from other folks. So I would say vote your conscience on the amendment, and I think with the expectation that we will hear this issue one way or the other again in session, but I think the bill is certainly worth carrying forward either way, is my opinion. Any other comments before I take votes on this? Okay, so we are voting on the amendment on page 3, line 15, to delete the words audio or. If you're in favor of this amendment, please put your hand in front of your face. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I have lost somebody, but anyway, it passes. Okay, so the words audio or are removed. Then we'll take the vote on the bill. LSO, would you call the roll, please?
Madam Chairman, just one moment. Apologies, had a technical delay there. Madam Chairman, this is for the committee to sponsor 21 LSO 61 for the general session.
That's right, as amended on page 3 and on page 4.
Correct. Senator Baldwin,
Aye.
Senator Bouchard,
Aye.
Senator Pappas,
Aye.
Senator Schuler,
Aye.
Representative Barlow,
Aye.
Representative Klim,
Aye.
Representative Dayton Selman,
Aye.
Representative Hallinan,
Aye.
Representative Roscoe,
Aye.
Representative Stibar.
He seems to have put his thumb up.
Representative Stibar, aye. Representative Sweeney,
Aye.
Representative Yin,
Aye.
Co-Chairman Scott,
Aye.
Co-Chairman Wilson.
Aye.
The motion passes.
Okay, then the next bill that we just want to take a look at again is 21 LSO 0059, Community Health Center and Rural Health Clinic Assistance. And again, there was, this bill has even more language in it that was very COVID specific. And it seemed to Co-Chairman Scott and I that while we want very much to carry forward, at the very least, the repeal of the sunset date in the summer, there were some other tweaks that we thought could be, where we could continue to use this statute to enable the governor to spend, whether the CARES Act money is extended by Congress or that there might potentially be other federal funding. It was certainly a useful tool. Mainly it had not been funded by general fund in some while. So if you look in your inboxes, you should have received last night. I typed them up so that you wouldn't have to just go by my hearing, but we just have some amendments on here, and I will present it, and then we can, well, first I'll remind you of what the bill was. And then if we have a motion to re-vote on the bill for a general session, then if that passes, then I will present the amendments. But so this is an existing program. It's been in statute for, I don't know, 15 years or something more along those lines. And the original purpose of it was to provide funding for basically community health centers, rural health clinics. And as it passed out of the legislation originally to provide equipment or capital expenses. It's the sunset date. There was a sunset date originally. It's been a couple years ago, it was pushed forward. It's been pretty much unfunded lately, but we used this tool in May as a way to get, we were hoping, it didn't end up happening because we didn't end up having a special session, but we were hoping to enable the Department of Health to use an existing format to take some of the weight, the burden off of SLIB of funneling out CARES Act money into the community. That didn't end up happening. There were a lot of requests that did go through SLIB. I know they spent long days on a lot of these things. I listened in really painfully to about 8 hours one day and gave up before they were finished. So if you remember this bill, the meat of it is on page 3, and we were just authorizing them to reroute, I think we put 15 million at the time on page 5 through the program to enable the Department of Health to do it. So if we want to continue with this, in other words, you know, at this point, if there's no further federal funding and no CARES Act money, there's still value, I think, to bringing a bill, if for nothing else than to push the sunset date off, because I think the structure of the system, even if unfunded, you know, there may be funds in the future, and rather than redraft something in the future, I would at least want to get rid of the sunset date. But that's my thought. Any questions briefly on that before I ask if there's a motion or not? Okay, is there a motion about to bring this bill in the general session? Moved by Co-Chairman Scott, seconded by Representative Roscoe. Okay, so I'm just going to bring forward the amendments, and if you've got your email up there, you'll see the first amendment is on page 3, line 1, to delete the words "for the period," in other words, to delete the specific time period. The sentence would begin, "Grants may be awarded." Okay, using funds from and subject to any, so it would still be grants from the CARES Act money, end of line 6, or from any other available federal funding. So in other words, this doesn't have anything to do with general fund money. It's merely providing authorization for CARES Act or other federal funding. So then the second line of the amendment is on line 7 and 8, deleting related to the COVID-19 emergency response, just because supposing that next spring the feds decide that they want to give out a whole lot of money for rural dentists or something, you know, whatever, that we didn't want. We thought, fine, let them use this structure, an existing structure, without recreating that. Then on page 3, line 21, upon execution of the grant, and so on to the next page, that was really specific to trying to get CARES Act money out before the end of December. It's not relevant anymore, so we would delete the entire section C and renumber. And then on page 5, line 9, we had the whole section 4 in there having to do with reappropriating $15 million from one of our special session bills and rerouting it through here. Again, that's really not relevant specifically. And we suggest instead just to make it clear that we have appropriated, there is appropriated to the department any federal funds designated by the governor for purposes of grants under 92127. And that would just provide authorization for them to go ahead and spend it. If federal grants come out, that would fit into this box. So those are the, that's my proposed amendment, and is there a second? Seconded by Co-Chairman Scott. Any discussion? Co-Chairman Scott.
Madam Chairman, speaking in favor of the amendment, what this does is it gives us a vehicle in case we do get an additional stimulus bill, which I think is at some point fairly likely. We'll have a vehicle we can use to say, this would be a good place to spend some of it. So I think the amendment makes some sense. It may be, you know, but I think by time of session, we'll know, is there, maybe has there been an additional one, or is there very likely to be one? And then we can judge whether to keep it in or not. But if we have it in to start with, we won't then have to say, have an argument over whether this is within this scope of the bill and the title of it. So I think it's better to have it in, and if we don't need it, we can take it out in session and revert to just having the extension of the sunset date, which I very much agree is worthwhile, because as safety net providers, these community health centers have proved to be quite valuable. And I'm thinking particularly the last time we had a malpractice crisis, they were extraordinarily useful, but also they can be useful in some other circumstances. So I think the right thing to do is extend the sunset and give us the flexibility to then deal with the specifics of any new stimulus that comes along. So I think I'm a little long-winded on that, but that's basically the argument for leaving it in, so we have flexibility during session.
Further discussion on the amendment? No. All right. Well, then let's vote on the amendment. If you're in favor of the amendment as you received by email and stated by me, please put your hand up in front of your face. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, 13-4. Any against? Representative Hallinan, I didn't see you vote at all, but okay, one for something. All right, that amendment passes. Okay, then is there any further discussion before we vote on the bill?
Ma'am, I would like to also note there is individuals signed up for public comment.
Oh, I'm glad you reminded me of that. Boy, thank you. Public comment on the bill.
Ma'am, I am going to admit Miss Jan Cartwright, Andy Somerville is here, and Ramsey Scott, and then you can call on them at your leisure.
Okay, boy, you would have thought I would get better as the summer wore on.
Madam Chairman, you're just getting a little less patient with Zoom.
I guess that could be. Okay, let's call on Ms. Cartwright because she hasn't been here yet.
Good morning, Madam Chairman. Jan Cartwright, Wyoming Primary Care Association Executive Director. I really want to thank Madam Chairman and Chairman Scott for your remarks. I just want to underscore some of the things you said in terms of the fact that this bill was signed into law in 2011, and we did see growth in the safety net between rural health clinics and community health centers. And another 200,000 after the original 1 million was put in the middle of the teens, and that money actually is still at work in our community in Sheridan. The Sheridan Health Center has applied for federal funding to become a community health center. So this has far-reaching impacts in a positive way. So we really appreciate that. And I just support the committee's amendments today. And thank you for the opportunity.
Okay, very good. Any questions for Ms. Cartwright? Okay, Mr. Scott.
There we go. Hi.
Hello.
Hi, Jaron Wilson, committee. Ramsey Scott, public policy manager with the Alzheimer's Association Wyoming chapter. Just want to echo Ms. Cartwright's sentiments and also the comments that both the co-chairs were speaking. These rural community health centers are a vital piece of the network of care. And specifically for those living with this Alzheimer's and their caregivers, being able to access good quality care and not having to travel an extended period of time is beyond words. Can't describe how vital that is. Just the easy access to care, both for those living with this disease. They don't have to travel hours, which can be very hard on their on for them, both just emotionally and mentally, and then for the caregivers to be able to access care quickly. We really do love the idea of being able to continue this bill forward. We hope that there's another stimulus bill coming or some form of support. And it would be really great for us to be able to just hit the ground running and not have to come back here. You guys have created a really great bill and really support putting the framework in place and extending the sunset on that. So I won't take up any more time and I'll stand for any questions.
Questions from Mr. Scott? Okay, thanks so much.
Thank you so much. I'll take care.
Ms. Somerville.
Thank you, Madam Chair. Just very brief comments. We support the bill and we support the amendments, and I'll just leave it there because I think everything else has been said. Stand for any questions.
Okay, questions for Ms. Somerville? All right, then let's take a vote on the bill. LSO.
Madam Chairman, I apologize, I was muted. Senator Baldwin.
Senator Baldwin, you're muted.
Aye.
Senator Bouchard.
Aye.
Senator Pappas.
Aye.
Senator Schuler.
Aye.
Representative Barlow.
Aye.
Representative Clem.
Aye.
Representative Dayton Selman.
Representative Dayton, we couldn't hear you.
Aye.
Thank you.
Representative Hallinan. Aye. Representative Roscoe.
Aye.
Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Representative Yin.
Aye.
Co-Chairman Scott.
Aye.
Co-Chairman Wilson.
Aye.
The motion has been adopted.
Okay, very good. Next up, we will hear the Ground Ambulance Service Provider Assessment Act, LSO 21 LSO 0179. Chairman Scott, who are we going to have? Are we going to ask LSO to present this? Ian, are you prepared, or have we a thought on this?
Madam Chairman, I am prepared. I don't know if Eric Bully or Eric Weatherford want to, they originally presented the bill, and if the committee might recall that then we voted to have the LSO prepare a bill that's consistent with their original outline. We have done that. The bill is still in substantially the same form, although there was, some things removed from the bill, some language changed. So I can do that, or either of the Erics can do that.
Ian, I think I would prefer to have you. I just think it's more appropriate that as a legislative tool that we present it, and then they can certainly pitch in and clarify or answer questions. But, if we're going to run a bill, we better be, well, we may have Ian presented on the floor, but at least it's in part of our system. Go ahead.
Thank you, Madam Chairman. I will do exactly that. Kind of taking a 30,000-foot view of this bill and what it does. It requires the Department of Health to approach CMS and the federal government about two options for enhanced payments to ground-based ambulance services. One option would be approval for enhanced payments. That would simply be a matter of increased reimbursement rates that would be approved by the federal government and then funded through a series of assessments on ground-based ambulance providers. That system is fairly straightforward in that it simply is enhanced rates, enhanced reimbursement rates for those providers. The second option, and the one you're probably more familiar with the bill, is what we call an upper payment limit program. That would also be funded through assessments to ground-based ambulance service providers. And that would be a matter of getting those payments to match what you call the upper payment limit or the upper payment limit gap, which is in the bill and defined in the bill. And that is that Medicaid has a system where they present a maximum amount that can be paid to an industry. And it's various industries are defined in different ways, but ground-based ambulance service providers are an industry. The idea would be to Medicaid would impose a maximum on the amount that could be paid to the industry. That is compared to the amount that is actually paid in reimbursements during a year. And the difference between those two amounts, provided that there is a difference, is called the upper payment limit gap. The idea is to impose assessment upon the ground-based ambulance providers that would cover that gap. The state would then send money to the federal government to get our federal match, our FMAP, on those rates, which then we would receive the extra 50% from the federal government. That amount would then be redistributed to the providers in the form of an enhanced payment. That in the bill is called a quarterly adjustment payment. The other payment that I previously discussed for the reimbursement rates would be simply known as the enhanced rate. I think that's important in this bill. I mean, before I get into the specifics of the individual provisions, is the idea that this bill sets up those two options. It requires our Department of Health to approach the federal government for approval of one or both of those programs, and then use this assessments to fund it. The idea behind the program is that it would be budget neutral to the state and to our general fund. There are several UPL programs already in existence in Wyoming. One's for private hospitals. There is another one for nursing care facilities. There's also a UPL program available. It's not in statute, but it's in our state plan for public providers. So this is a system that's already known to our statute, known to our current system. And this bill is in fact very closely modeled after two of the statutory programs for private hospitals and for nursing care facilities. More or less, it goes in lockstep with those two programs. I can go through the actual provisions of the bill. As with all bills, we have a number of definitions in the beginning of the bill. The definitions do make clear that this program is available only to ground-based ambulance services, licensed ambulance services. That's important because the language of the bill would exclude air ambulance services. On page 4 of the bill, kind of skipping ahead through some of the technical definitions, we do define the term rate enhancements and then quarterly adjustment payments. Again, I think that's just an important distinction to make the committee aware that this bill does provide for two options. One would be quarterly enhanced payments, which is the equivalent of the UPL program, and the other would be a more simple, just increased reimbursement rates. On page 5, we set up this account that funds these programs and would take the amounts that are assessed. These provisions are very similar to the other provisions in the other UPL programs. Subsection C and that page starts to tell what the monies that can be placed into the account, including the assessments, including the federal matching funds that become available through those assessments. On page 6 and subsection D explains what the authorized expenses are from those accounts. These bills, as do the other UPL bills, allow an administrative fee to be charged by the department to help pay their costs of not more than 1%. The funds can, of course, be used then to match, to provide the match for the federal funds that will become available. Moving on to page 7. On those paragraphs, it talks about that the funds can, of course, then also be used to repay any amounts that are due to the federal government. This would be if the program was discontinued or for some unforeseen circumstance. It would be an extraordinary circumstance, but it's important to make sure that the funds would be available to make the state even with the federal government should they need repaid. Also then after any required payments are made to the federal government, again, in the case of an emergency, paragraph 4 on the bottom of page 7 makes clear that providers could actually be refunded any errant payments. So if they made payments for the assessments, but somehow did not receive any the benefits that were earned by them or due to them, then after other amounts are paid, we would be able to repay those providers. Moving on to page 8. This sets up the actual provisions for payment of the assessment from providers. Subsection A, I think, makes clear that all ground-based ambulance service providers do pay the assessment. On B, it explains the amount. The amount is based on their net revenues during a year. Again, I explained in the beginning of this how that works. They're going to pay an assessment that tries to equal the amount, the difference between the total upper payment limit and set by the federal government and the amounts that have actually been paid in Medicaid reimbursements to the providers through that same year. So the Department of Health would set that amount, the total amount that's needed, and then dependent on each individual provider's net revenues, they would they would pay a proportional amount to equal that, what we call the upper payment limit gap. Those payments would be due on a quarterly basis at that point. This paragraph also, again on page 8, makes clear that there's two different things going on though. First of all, there's that payment that I just discussed, that for an upper payment limit program, but also there would be, if it's a simply matter of enhanced reimbursement rates, then the same assessment would go into effect that would be made to make up the state's portion of the enhanced enhanced rates. That way, again, the state is, the impact of the bill is budget neutral. Either way, it gets the benefit gets paid through these assessments. Moving on to page 9, it sets the payment dates and the schedule. Again, it's quarterly. It is important to say that these payments, these assessments are not due under this statute until a federal program is authorized, and specifically 40 days after the state plan is amended or after the Department of Health has otherwise reached an agreement with the federal government. I think that needs to be clear. On page 9, subsection D provides what happens if a provider goes out of business partway through the year or quits, the assessment becomes undue, that they owe a pro rata rate of what would have otherwise been due. On page 10, the new statute, section 105, provides the penalties if providers do not pay, a 5% penalty specifically. And then the department has a couple of other remedies that are described on page 10 and 11. They can withhold other Medicaid payments, including a quarterly adjustment payments or rate enhancements, or they can provide for an installment plan from those providers to get caught up on what payments are due. On page 11, you do have a staff comment that brings up the fact that paragraph 3 or subparagraph 3 is included, which would allow the department to suspend or revoke a ground ambulance service provider's license. I bring up in that staff comment that is a penalty that is allowed under some UPL programs, but not all. So I think that's a policy question that the committee should consider. Section 106 sets out the payments that are due under this program. Again, there's two types of payments. There's one, a quarterly adjustment payment in the UPL program, or there would be simply enhanced reimbursement rates. And it sets out the requirements for each. Subsection B starts with the quarterly payments under the UPL program. It's important to note on page 13 that starting in subsection C, at Senator Scott's request, this bill does insert some qualification criteria for those providers who would actually receive the quarterly adjustment payments under a UPL program. And those are, I don't know if Senator Scott, if you'd prefer to describe those or if you'd like me to do it.
Madam Chairman.
Co-Chairman Scott.
Madam Chairman, yeah, what we're doing here is saying that in order to get the payments, you have to be willing to take Medicare, which got accidentally omitted, Medicaid, or get in network and get network with the major insurers in the state, and that's there because we were told that there was a particular problem in Fremont County. It turns out to have extended to Laramie County as well, in part with the dominant provider not being available to everybody or not being available at a reasonable cost. We thought that if we're going to enhance their Medicaid payment, it ought to be for an outfit that was providing service generally to the public, and that would make a lot of sense. It's the LSO has properly qualified it, so if the feds object, then we don't have to have it, and I think that's important. There's some technical amendments that are needed here, but that's the purpose of it. We were told we were going to get some opposition from representatives from our counties if we didn't do something about that particular problem that they've got that seems to have been causing some of their constituents quite a problem.
Okay, Ian.
Very good. So that's those provisions on page 14, talks about those. It is interesting in that it makes clear that you have to meet all of those requirements, as Senator Scott explained. You have to be a network provider, or if you're not a network provider, then you have to have made an offer, a bona fide offer to become a network provider, and then it sets some standards for what that means. As it currently reads, that you either have to be a network provider by being willing to accept double the amount of a Medicaid reimbursement rate, or if you can show that the cost of providing your service is more than double the Medicaid rate plus 6%, then that also satisfies the requirement. Subsection D on page 14 describes just if the department is pursuing the enhanced reimbursement rates, then simply those payments need to be made subject to whatever agreement we have the feds to make those. It's a more simple provision. On page 15, it makes clear that the Department of Health can't reduce or offset other payments that are due providers through this program. In other words, the program is not meant to reduce overall payments to providers, nor does this makes clear is it intended to reduce the state's obligation to those providers by reducing general fund expenditures or otherwise. The idea is that it is meant to be a supplemental payment program, not a replacement for other types of payment or obligations from the state. Also consistent with the committee's request last time, subsection F on page 15 does make clear that no service provider is guaranteed any payment from this program. They do have to pay the assessments, but it's not guaranteed that the payments of the program are going to offset those assessments or otherwise be equal or more than those assessments. Of course, the reason the program would be there is because you hope that they are, but the state nevertheless does not have an obligation to make sure that they are. Section 107 talks about discontinuation of the payments or the assessments. These would be a situation where, for instance, if CMS does not approve a plan with the state or withdraws its approval of a plan with the state, the assessments would no longer be collected, and then no payments would also be made. If federal match money disappears, so that it no longer is either beneficial or it can't, there's no way to pay for these assessments, then the assessments would no longer be made. On page 17, again, it makes clear that if that happens and after any delinquent payments or other payments that have to be made back to the federal government are made, then the service providers themselves can be reimbursed for assessments they made for which they never received an earned benefit. On page 108, on page 17 in section 108, it talks about the approval of the state plan and rulemaking. This is the provision on page 18 that requires the department to go ahead and work with the federal government to modify our state Medicaid plan or in other ways make an agreement to approve. Again, I'll say it's important because I think it requires them to approve either a UPL program or an enhanced rate program with the federal government. Importantly, also on lines 8 through 12 and a couple of places in this bill, it allows the department to modify the plan that it goes forward with the federal government consistent with this bill and the authority given in the bill, but it does allow them to modify their proposal in order to get approval from the federal government if some changes need to be made. And then subsection B on page 18, of course, requires rules by the department consistent with this. Section 109 simply declares that if you own multiple businesses, each separately licensed, then you'll be required to pay an assessment for each one. Chairman Scott, did you have a question?
Yeah, Madam Chairman, if I may.
Go, Chairman Scott.
A technical question for Ian. You've got the two different approaches that are both authorized. It's conceivable to me that the feds may say, we want one approach for, say, public providers and another one for private ones. The CMS is a little unpredictable that way. Is it clear that the department can say, we'll use the enhanced payment method for say private and the UPL for public or vice versa, if whichever satisfies CMS, and so we have two very similar but technically different programs here. Is that possible the way this is written?
Mr. Chairman, I'm sorry, Madam Chairman. Mr. Chairman, I believe that is possible under this bill. It allows that flexibility. Having said that, as we go forward, I'll make sure of that because I think that is certainly a possibility, as you mentioned. But yes, I think the bill is drafted so that would be possible. Good. So then section 2 on page 19 and 20 of the bill is interesting. It may be subject to amendment later on. This is the part that the committee specifically asked where For public providers, the statutes, Wyoming statutes already allow an intergovernmental transfer to occur. And I talked to Don Richards with our budget fiscal division. He made clear that that is already happening with the other UPL programs, and that it just allows a transfer of money within the departments, within the executive branch to provide for these payments so that the matching funds can be used to pay an assessment so that they can get back the match from the federal government. I talked to Don something of quite a bit about this provision just to make sure that he was comfortable with it. But his words to me was that he thinks the existing language has never, he didn't opine whether or not the statute needs to be changed, but indicated that there's never been much doubt about what its intent was. And then in fact, it's worked flawlessly so far with the other UPL programs. I've had some discussions with Eric Weatherford and Eric Boley as we were preparing this bill, and both LSO and I don't mean to speak for them, but I think we're all in agreement that there are some issues with adding this language that is below. What this language does, it simply gives examples of what kind of programs could be used for these upper payment limits, for these intergovernment transfers. Some of the concerns we have is that some of the UPL programs are not codified. Some of them are ones, but one of the ones that's codified is for private providers, private hospitals, in which case they wouldn't likely qualify for an intergovernmental transfer anyway. Given that testimony, I think that LSO might suggest the committee consider just getting rid of this amendment to the existing intergovernmental transfer language, because I'm not sure it adds much. I don't think it adds much, and it may cause some confusion. But either way, the language that is provided does provide an example. It simply provides language that gives examples of when this intergovernmental transfer can be used. The final page of the bill is section 3. It's effective immediately. I just want to make clear that just because it's effective immediately doesn't mean that providers start getting an assessment from the day the bill is signed by the governor. Instead, the bill makes clear that there is no assessment charged until 45 days after a federal plan is approved. Madam Chair, I think that's it. If there are any questions.
Okay. Questions for Ian? And we'll invite the Erics on after this, but Ian, I do have one question. So following on your last remarks about the intergovernmental transfer. So in that case, if we thought it made sense to not have that amendment, then we would actually delete all of section 2. Is that right?
Madam Chair, that's correct.
Okay. All right. Do we have, is there any, well, let's see. Let's take public comment on the bill, and then I'll try to do this in proper order. Public comment and then amendments, I guess. Do we have the Erics? Or yes?
Ma'am, I
Yes,
will
ma'am.
admit both Erics, but we also have an individual from the Department of Health, should you have any questions.
Very good. All right. Well, let's start with agency. Mr. Springer, welcome. I don't feel like we've seen you in a while. Where'd he go? He was on and then his picture, oh, there he is, in front of, oh, very lovely. Nice aspens. Jesse, have you got anything for us?
I'm available for questions.
Okay, you
Chairman
don't have any
Wilson.
comments?
No comments.
Is the current upper payment limit programs are working fine, as far as you know?
They are working fine. They're a lot of work. So generally these have been added without any staffing. So there's been, it just adds to the amount of work to be done. So that's been a challenge. I think when we've only had a nursing home program, and then we had a hospital program, and then we added the private hospital program, and then we have this ambulance program. Each of these takes a little bit of work to do. And there, I think, are some other proposals for these type of programs that, could be explored. But generally it's just a scramble to make sure we get these covered, because it's just, it's never been added with staffing. And they're relatively resource intensive to add, because you have to do financial reporting and things like that.
All right, so it's not on the topic as to whether we want an upper payment limit for every physician and nurse practitioner yet in the state, but that will come back to, I wasn't suggesting it, just detecting. Representative Barlow.
Thank you, Madam Chairman. That was actually my interest, was what is the the demand upon the department to do this. And is 1% adequate? As this bill lays out, they can keep 1% for administrative costs, the way this bill is. Second is, are there any of the upper payment limit structures that are based on net revenues? Because it seems to me that's a step further than I recall on some of the others, but net revenue versus just reimbursement rates or whatever. Thank you.
Jesse?
So to the second part, most of them I think are based on net revenues. So they're based on total computable. So most of them I don't think are actually based on the per diem rate or anything like that. They look at the total revenue versus what Medicare would have paid, and if there's a gap there globally for that entire provider group, then there's money to be paid. But and then it looks at the gap for each provider type. So we have these programs for nursing homes, for hospitals, for physician attached hospitals. That one's coming soon. It's been approved, but we're waiting for CMS approval. So each one of those has a gap calculated, but it's generally calculated globally on their whole business.
So as to his question about the 1%, does that suffice?
Well, so what we use the 1% for, so we generally these bills have created the ability to keep 1%, but not to spend 1%. So they don't create an expenditure account for the Department of Health to actually spend the 1%. They just have the ability to collect the 1%. So we generally don't have any ability to spend that. But what we do, if we did have any ability to spend that, we would generally spend this on the 2 accounting or actuary firms we have that run these programs for us. So that we have a staff member that manages those, and then we have a group of people that are associated, that are state staff members. But we generally hire 1 of 2 contractors to run these programs. And they do all the cost calculations and the UPL and all those type of things. And then the state staff are a lot of times doing the collections of the revenue, sending the letters, making the actual disbursements, those type of things.
So
and
Jesse,
I think we provided the 1%. So I think we provided an estimate of costs to run the program. And I think at the time 1% was sufficient. I'm not 100% certain on that, but generally we come up with a cost estimate when we look at these bills to run the program and give an estimate of what that would be. I would guess this would cost about $100,000 to run. So I'm not sure if that's 1% or not of what we've estimated, but it just depends, honestly, how complicated it is and how easy it is to work with the different provider groups that are subject to the assessment.
So Jesse, if you're feeling that we haven't given actual spending authority, do you happen to know what happens to the 1% that you collect? Does it just go into your healthcare finance department revenue pot, or what?
I believe anything that's not designated goes to the general fund, Chairman Wilson.
Wow.
There's not actually a healthcare financing operating account or any sort of special revenue account. We just operate out of the general fund.
Co-Chairman Scott.
Madam Chairman, 2 points. I would suggest from what we were just discussing that that's a general issue with these things that Health Department needs to raise with the Appropriations Committee. I think we would be probably stepping a little out of line if we try to settle that one. Because it sounds like you need to have some kind of uniform system across the whole lot of them, and that can be best dealt with during a budget process. What the question I have for Mr. Springer, we've had real problems with our EMTs being pretty fragile right across the state. And I'm sure COVID-19 has not helped that problem, probably made it significantly worse. And we're, with the budget situations, what they are, they're likely to see some budget cuts. Notwithstanding the fact they're pretty fragile. So these are going to be, this bill is pretty critical to a service that we absolutely have to have. How long do you think it's going to take to get federal approval for this thing if we pass it?
Chairman Wilson,
Yes.
Senator Chair. Sorry, is someone speaking? Okay. The physician tax, I think, is a good test. It's taken about a year. I think it took about 6 months to write the assessment. I think depending on the complexity assessment, this I think could be relatively simpler compared to some of those. And then they have, generally they should be getting approved in 6 months, but if they return questions to, if CMS returns questions to the state, they can restart their clocks. So it can actually end up taking longer, but it just depends how quickly can we get this submitted and then start the clock with the federal government. But yeah, I think to the other points you made, Senator Scott, it does help a lot because it softens the blow of any rate reductions because they can capture any amount that we're not paying them as a state between our rates and Medicare rates.
Representative Roscoe, I see your blue hand up.
Oh, thank you, Madam Chairman. Mr. Springer, why was the air ambulance not included in this bill? I probably should know that answer, but thank you.
Mr. Springer.
That's a great question. I believe it's because we cannot subject the air ambulances to a tax because of the same discussions that have been had over the years about the state regulating the air ambulances at all. I think I would have to defer to the LSO on why that was done.
I would imagine that is it, but yes, Ian.
Madam Chairman, I believe Senator Scott may have an answer, but I don't, but I can, the answer is that was the direction of the committee. Seemed to make clear from the beginning that it wanted to be ground ambulance only. There may in fact be, as Jesse just mentioned, issues with the taxation under the Federal Air Deregulation Act as well. But
Co-Chairman Scott.
Madam Chairman, that's exactly right. Why we instructed this was to be ground only. You get into all kinds of complications with that federal preemption in the Airline Deregulation Act. And you couldn't predict how it would actually operate because of that. And I think those uncertainties would cause the bill to go by the wayside. So for all those reasons, we said at the outset, let's limit this to just ground ambulance. And that's what Mr. Boley approached us with, was strictly that. And I think he can speak for himself, but I think for exactly the same reasons.
Okay, thank you. LSO, before I call on Representative Hallinan, who I see has his blue hand up as well, I am not managing to put down people's hands. And LSO, could you just check, am I properly in as a host? Or have I just failed in another category to remember how to operate Zoom? Representative Hallinan.
Thank you, Madam Chairman. I want to have a little bit of explanation on how this program works. As I understand it, Medicaid and Medicare have the amounts that are approved by the federal government to pay for these ambulance services. And then they also are being asked to give an upper payment limit And I wonder how that upper payment limit relates to the initial payment. The assessment then would go against the provider, and they would pay that money. I guess they'd pay that money into this account. And then they would get the money back from this account if it was supplemented by the federal government. So is that how this program works?
And Representative Hallinan, I'm going to try answering that just to make sure that I have worked these things over for like the last 6 years or so that we've been doing this, and then I can be corrected. But I think we should all practice trying to explain this, because we'll all be called upon it in session. And I will tell you, I remember the first one that we did when I was on Labor Committee before. A lot of us kind of had our eyeballs roll around and think, what the heck is this? But so Representative Hallinan, you're essentially right in that the feds have said, let's just say, the maximum you could pay for something between you and us is $100. Well, then if we, let's say, set our rate at $45 and it were matched by the federal government at $45, we've together only collected 90. They're saying, well, really, you could collect another 10 if you wanted to. And they have authorized, and I actually spent several hours on Saturday reading the Federal Register, which is a very painful experience, but if you want to look, it's 42 CFR 433.68. And the idea is that if you get some of the providers, whether nursing homes, hospitals, EMTs, to throw in some of their own money, essentially have some skin in the game, not just general fund, they could put in, let's just say, an extra $3, and then the feds would match not only our general fund 45, but the providers 3, and that way we would get back 48, and that goes, so then the provider gets, yes, his 3 back, plus the additional 3 that had been matched by the feds. So that's my cheap and easy explanation of what 6 years ago seemed to many of us like the craziest idea we ever heard of. And I'll go on from there because I'm going to next call upon Eric Boley and then Eric Weatherford, and they can either say, Chairman Wilson, be sure not to talk on the floor, or at the very least, answer Representative Hallinan's question. Representative Hallinan, did you have another question?
No, thank you, Madam Chairman. I think your explanation is pretty good, but I still am somewhat confused by it.
It's only good if it's right. Mr. Boley. And there you go.
Good morning, Madam Chairman. Eric Boley with the Wyoming Hospital Association. If it's all right, could I have Eric Weatherford join and the two of us can kind of tag team this as much as needed?
Go right ahead. Go ahead, Elizabeth, let him in. There he is.
So the first thing I'd like to say is how grateful we are for Ian and the hard work he's done. You guys are very blessed to have Ian working for you, and he's done a lot of work with us to get this bill to where it is right now. So we appreciate that work. And we can walk through the intricacies of this. Eric's an expert on this, even more than I am. You deserve a medal for reading the registry. You should have better things to do with your Saturday than to read that, but we appreciate the hard work you're putting into it too. The reason that we decided to go with ground transport as opposed to all EMS, there's a lot of controversy around air ambulance right now. We really are worried about our EMS services around the state. And so our intent was to try and find a way to buoy them up and to shore them up and to help them with the issues they're facing right now financially. And so that's why we approached it the way that we did. As far as Dr. Hallinan's, Representative Hallinan's question, it's complicated, but it isn't once you understand it. And basically, and I'll allow Eric to jump in here if I go off the rails, but all these upper payment limit programs, there's a maximum that we could be paid from the federal government that we are not paid. And for each state, that maximum is set. through provider assessments. And that's basically what this is. We're assessing different types of providers to collect what the state would normally have to pay in order to draw down additional federal funds. And so we're assessing ourselves so that we can get matching federal funds to bring us closer to the cap that we could potentially pay if those were the rates that the state had set to reimburse under Medicaid. Eric, is that a good description?
Yeah, that's perfect, Madam Chairman. I think Eric and you hit the nail right on the head. The bottom line is states don't have stacks of money laying around to get these providers up to the limits that are set by CMS. But we've got some opportunities, as you pointed out, through the healthcare related taxes, through intergovernmental transfer mechanisms to help those providers capture that difference. And we've done it through the Hospital Assessment Act, and we're looking to do the same thing through the physician, hospital related physicians. And now we're looking to try to help out the ambulances as well. And I think you also pointed out in response to the question about grant on the ambulance, and Mr. Boley's response there as well is correct. But I don't believe, and I'm not an expert in aviation law, but I do not believe we could tax those providers either for their aviation services. So yeah, I'm just reiterating what you guys said. Great job.
Okay, I've kind of lost track of where we're at. We were, I guess, doing testimony before we had questions. Mr. Boley, did you have anything further to add to the testimony on the bill?
Madam Chairman, thank you. The thing that I'd let you know, we've been working closely with the EMS Association. We have their support. We've spent time educating them on what this means and how it can help them. One thing that I'd like to address, we in all of these UPL programs, we've earmarked or we've allocated 1% of the money towards helping the Department of Health administer these programs. I actually am kind of shocked that they don't get that money, and I think that's something that we could fix. But as you look at the millions of dollars that we bring in annually, and the Department of Health uses those upper payment limit amounts to help show how much of the actual cost is covered for a Medicaid patient. So without the UPL programs, the cost coverage for any of our different types of providers is much less than what is actually shown. We're actually bringing in close to $60 million a year, I believe, through all the different programs for nursing homes, hospitals, and now with the physician UPL that we're waiting on CMS to approve. This one will bring additional funding, but we want that 1% to go towards the Department of Health's efforts in helping us with these programs. The other thing that I'd also offer, Eric has, in his firm, have great experience with UPLs all across the country. We're willing to help draft the state plan amendment and take some of the burden off of the state, and then we would give it to them for approval. But we're willing to do whatever is necessary to help ease the burden at our expense, so that we can get these programs done and help the Department of Health. So we're offering that. We've actually asked for a meeting with one of the contractors that does the calculations. We think there might be ways that we can capitalize on some of the other programs. And so we're actively involved with the staff within the Department of Health to try and make this as easy as possible for them, but also to make it as beneficial as possible for all the different recipients.
Great. Further questions for Mr. Boley? Representative Barlow.
Thank you, Madam Chairman. So I guess my question goes to how many service providers we have in the state and what are the different types, meaning county-run, private, et cetera, whether they need to be part of this discussion as well. And then for some of them, is there even a net revenue calculation? Meaning if they're a provided through I guess what I would call a hospital district or a county memorial hospital, are they even doing that kind of accounting where they could take advantage of that? So what types, how many providers, what different types, and are there nuances between them about whether they could implement this? Thank you, Madam Chairman.
Mr. Bullock.
Madam Chairman, Representative Barlow, I'm going to have Eric jump in here with me too. He's helped with the calculations, but yes, there are different types of providers. We've requested the information from the state EMS office. We use that in our initial modeling. For the public EMS services, those that are either owned or operated by hospital districts, memorial hospitals, or by the counties, there are mechanisms in place. We would use IGTs more than likely for those intergovernmental transfers as opposed to the private services. But there are nuances, and there are ways that through using the different types of UPLs that we have in the past that we can benefit most. There are some out there that don't do any billing. They're subsidized by their counties and they don't bill at all. This would actually, we would hope, be an incentive for them to start billing and then receiving the benefits of this. I'm going to defer a little bit though. Eric might be able to give you some more numbers, Representative Barlow, Chairman Wilson, if that's all right.
Mr. Weatherford.
Sure. So we have a list of the providers in the state. I would say the vast majority are owned by a public entity, whether it be just an ambulance district itself or by a public hospital. I guess my answer to the second question is how will they have their revenues? They'll have to let us know what their revenues are for their transportation services. As far as how many private and public providers there are, just kind of looking at the list, it looks like there's about 17 private providers and about closer to, looks like about 53 public providers. So the public providers really wouldn't participate in any way related to this bill, because as we mentioned, they are going to participate via the intergovernmental transfer program. This really impacts primarily the privately owned providers.
Madam Chairman, the one thing I might also add, if it's all right, for Representative Barlow, for those that are public, for the hospital districts, the memorial hospitals, they definitely are able to account for this through different cost centers. So we would be able to carve that out for their intergovernmental transfer portions.
Okay, Representative Hallinan.
Thank you, Madam Chairman. I have one more question on how this works. If the amount of Medicaid paid by the state and the feds is $90 and the upper payment limit is $100, and you said in or somebody said in one of their discussions about this, that $3 would be put in as the assessment against the provider, then I'd like to know why they don't put in $10, and then the feds would equal $10, and then it would be, they'd get $110 back. Why would, or is that limited by the amount that they can get by the upper payment limit? Thank you, Madam Chairman.
Thank you. And I'm going to just try on this again so I can practice, because I really foresee that some of us is going to have to run this darn bill. I would hypothesize that first, yes, there's a maximum limit. So we can't just put in $300 and get even more. I mean, you know, they've said this is the limit. So you can only put in enough to get back the limit. The other thing is, and I tell you, reading the Federal Register, I don't know why Mr. Boley suggested that my life was so boring that I had to read the Federal Register on Saturday, but there is I don't have it in front of me and I didn't memorize all the legalese, but there is some sort of a 6% cap after which they evidently think you're running a scam or something. I don't know, but there was something, there is a percentage thing in there as well. That's just my little, hopefully all of my explanations will carry things forward on the floor. Mr. Boley, have you got a better answer?
Madam Chairman, I think Mr. Weatherford has
Mr. Weatherford
an answer for you, but you did great.
No, you really did. So the answer is, if we are doing an upper payment limit, which we consider be what we'll call a supplemental payment program, and that's where we would do a quarterly lump sum payment to the providers. The feds will likely calculate a cap based on the average commercial rates that are available to providers in the community. And so that will just establish a hard cap, and we'll have to look for the gap between that average commercial rate and what the provider is getting paid. And then let's say it is the $10, then we'll calculate what we need to assess those providers, and basically we'll do it in the aggregate because we have to assess people across the board the same rate, but we'll assess the providers the amount we need to get them generally up to that number. Now, it's never going to be perfect because the number is never going to be a nice, pretty round number, but we're going to try to get them up to the maximum we can get. And that would be the way an upper payment or supplemental payment program would work. Now, if we did a rate enhancement program where we just increase the rates, that's a little bit different because all we're doing is increasing the rates that you would pay to the providers. In that case, really the rate increase is just subject to CMS's approval. And they may or may not do a calculation based on the average commercial rates in the community. I will tell you, they hadn't down here in Texas on hospitals before this year, and now they have when we've done rate increases. So maybe they would. I don't believe they've done it on ambulance in other areas when they've done rate increases, but it's something we could try, and it would also give us a lot of flexibility. The nice thing about a rate increase is all you do is ask CMS for a rate increase, and if they say yes, then great, we've got increased rates, and it's frankly probably a little bit easier for the department to administer that. I don't want to volunteer for Mr. Springer though, so maybe I shouldn't do that. So that's a long-winded way of saying really it could depend on how we structure this, whether it's a rate enhancement or a supplemental payment. But the bottom line is there will be a hard cap that we will have to use if it's a supplemental payment. And that's how we'll calculate the amount we can assess.
And just thank you, Mr. Weatherford. And just to point out, members, on the staff comment on the bottom of page 6 and the top of page 7 does note that LSO assumes the assessment required by this bill, if we had a rate enhancement, would be set at an amount that would cover the state's 50% share. In other words, we don't want to set a rate increase that needs general fund money because we haven't got any. So we would have to set a rate increase at a level at which the additional amount would basically be covered by the assessment. So that's I take to be the gist of that LSO note. Representative Hallinan, did you have another question?
Well, I guess I think you kind of answered that question just now, but the amount that would be in a rate increase, wouldn't that have to be paid for half by the state?
Well, and you're right, Representative Hallinan, and that's where the contribution to the state's part, the increase of the rate, we would be collecting the assessment from the providers to basically pay our part.
Okay.
I mean, I think mathematically it works. I mean, we're trying to get to the same point by either methodology in terms of our funding, I think. Mr. Weatherford, do you have any more comments that you want to make about the bill before we call for a motion on the bill?
No, Madam Chairman.
Ma'am?
Yes, all right, good.
We do
Elizabeth, I thought of it before you called upon me. Is there any other public comment?
We do have one other person I will admit at this time, ma'am. His name is Mark.
Hello there. If you could introduce yourself. It says Linda, but might be somebody else. And you're muted too, Linda.
Sorry about that. My wife used my Zoom. My name is Mark Burnham. I'm from Global Medical Response.
Okay, what do you have to tell us?
Well, I'm here today. Just want to thank you, Madam Chairwoman and Co-Chair Scott, for letting me join. I'm joining as Linda, but my real name is Mark. My wife used my Zoom. We both work from home. I'm from Global Medical Response. Like I said, we're the parent company of American Medical Response, which is one of the ambulance providers in Wyoming. And I just want to thank Eric and Eric's, or as I like to call them, Eric Squared, for keeping me up to date and meeting with me and, listening in. Co-Chairman Scott answered almost every question I had to ask you today. So it was good just listening in, because like my grandpa always said, sometimes if you just shut up and listen, your answers will be there. So the questions I had were just on the upper payment limits you've went over. And then another question I had was about the bona fide and reasonable attempts to become a network provider, because we are working hard with a lot of the insurance companies in the area to become network providers for our companies, but we have to go through a certain process and meetings and just back and forth. So we just wanted to make sure what that requirement was. And I think that was been answered by Co-Chairman Scott as he went through that. And I really appreciate that. And your example, we do this with our company. We've done bills like this in 6 other states, and you gave a excellent explanation of how it works. I think it was really good. It was simple and right to the point. So I just wanted to make sure that everyone knew that from the private ambulance side, American Medical Response, Global Medical Response, we're standing behind Eric and want to work with the state to see what we can do to help. And also, we're really looking at ways to reach out to rural Wyoming. I was born in Casper, Natrona County Hospital, and my family is all from that area. And I really think it's something that's important to make sure that we're looking after our EMTs. And that's why we have some issues with getting into network, because we provide a very good salary for our employees. So our private ambulance EMTs who are out there working every day, we want to make sure they're paid the best they can. So sometimes it's really hard working in network because they don't understand our costs versus a volunteer agency where we're paying for insurance, we're paying for the equipment, all these things that we're not getting subsidized for. So sometimes it looks like we're asking for more money when it's really we're just trying to cover our cost. And so I just want to make sure I came here in support, and I just thank everyone for letting me be here, and I'll shut up now and just continue to listen. Thank you very much.
Questions for Mr. Burnham? And Mr. Burnham, we're glad to see you in a little rectangle. We hope to never open our eyes and look up and see you with the sky behind you. Fine man that you are. Thanks very much for what all of your folks do. Oh, I think I see Chairman Scott's hand.
Madam Chairman, and I have a question for Eric Weatherford.
Thanks, Mr. Burnham. I guess no other questions for Mr. Burnham? Okay, Chairman Scott, go ahead for Mr. Weatherford.
For Mr. Weatherford, wanted to be clear and make sure I didn't misunderstand something that Mr. Weatherford said. will this bill affect the public providers, the volunteers, the ones where it's a hospital district or a county fire department or something like that that's providing the service? You said something about intergovernmental transfers. Is this bill strictly for private ones, or is this going to have an effect on the public ones too? I'm confused.
No, this bill is designed to only allow for an assessment of the private providers, but we anticipate submitting a state plan amendment to implement a program for the public providers that would do the same thing. They would just fund it through an intergovernmental transfer. So we're not looking to carve them out of the Medicaid reimbursement side. We just don't need to assess them because they've got the intergovernmental transfer mechanism.
Chairman Scott.
But that mechanism is not currently being used. Am I right in understanding that? And the anticipation is if this bill succeeds, then the department will go forward with implementing an intergovernmental transfer system for the public providers that will in practice look very similar to what we're doing here for the private providers. Am I correct in that?
Mr. Chairman, that's the goal.
And to that, Mr. Springer, is that your understanding?
Well, I understand this bill actually creates the authority to run both programs. So the intergovernmental transfers are mentioned. So currently in statute, we do not have the authority to collect intergovernmental transfers from ambulances or to make disbursements to them. So I believe this bill does actually create the statutory mechanism for both programs. We would then proceed with 2 state plan amendments to set out how we would run the program. The assessment, so the private hospitals or private ambulance assessment, I believe is created here. But I believe the authority for the intergovernmental transfers is also created here.
So Jesse, along those lines, then on page 19, we had some discussion earlier about whether we maybe didn't need section 2 referring to the intergovernmental transfer because LSO stated that they thought perhaps listing the Nursing Care Facility Assessment Act, the Private Hospital Assessment Act, and so on might just cause more confusion than it benefited. But it sounds to me like you're saying that you think that without, I mean, it's under the existing 424104 powers and duties of Department of Health, it says that you can enter into intergovernmental transfer arrangements, and the amending language listing the nursing care facility and hospital and whatnot is not there now, and yet you are getting that money. So what is your thinking about the utility of that paragraph?
Well, I think I'm just trying to, sorry, Chairman Wilson, the entire bill sets out the structure of making the expenditures. So I believe under the existing statute, without the red text, we could do the intergovernmental transfers in order to execute the rest of the bill, which is to make expenditures. So I think that was correctly stated. I just wanted to be clear, without the bill at all, there was no ability to, we could possibly do an intergovernmental transfer, but to what end? Because the statute does not allow us to make a disbursement to an ambulance currently.
Okay.
So under current statute, there is no mechanism to make a supplemental payment to an ambulance. So, you know, we have the authority to do intergovernmental transfers, but to what end?
Okay.
And I think the rest of the bill sets that out.
So if we were at my earlier question about deleting section 2 to reduce confusion, that would still be okay as far as your.
Chairman Wilson, I believe the red text would be fine to remove, from what I understand from the bill. And yeah, I don't think we've actually amended that section as we've added different assessments. So we've had sufficient statutory authority with just that sentence for the other assessments that have been added.
Okay. Okay, Co-Chairman Scott and then Representative Barlow.
Madam Chairman, same basic question for Ian Shaw. Yeah, is that your understanding of the bill, that the balance of the bill does give them the authority they would need to make payments to the public providers based on an intergovernmental transfer, and that absent this bill, they probably don't have that authority?
Ian?
Madam Chairman, that is correct. And I think what Mr. Springer said is exactly right. That by adding the payment authority and allowing a mechanism for that to happen in the intergovernmental transfer becomes available like it is now, but there would be no reason to assess it right now because there would be no mechanism for payment. So yes, I think that this does that task.
Representative Barlow.
Thank you, Madam Chairman. So I understand the not needing the red language, but I am curious whether there should be an addition of services, because currently these IGTs are only allowed for qualifying facilities. And I would suggest that we're talking about now a service that may or may not be associated with a facility as a hospital or et cetera, particularly on the private side. And so I wonder if we should be thinking about, and this is for something for Mr. Shaw maybe, and Mr. Weatherford, whether we should be saying qualifying facilities or services, because I don't think facilities is a licensure thing, and this is another licensure thing, but it's not actually licensing a facility, it's licensing provision of a service type. So I just throw that out there. It's something we may want to consider for this section too. Take out the suggested language, but make sure we're not going to actually hamstring services if we can't actually then do it.
Ian, thoughts on that?
Madam Chairman, I think that intuitively makes sense. I don't know that that is something that hasn't been interpreted by the department or by our budget fiscal folks previously as creating a problem, but certainly, as he points out, a facility may be different than a service provider. Mr. Springer has concentrated on that language specifically in what transfers would be available, but I certainly don't see any harm in making that amendment.
Did I see Mr. Bowley or Mr. Weatherford having looked like you were motioning as to have some thought on that, or was that just coincidental? No, you're good. Okay. All right. Let's see. I'm trying to. We have heard. Any more questions on the bit, Mr. Springer?
To Representative Barlow's point, I think and providers at the end of that assessment session could make sense, because they, by definition, ambulances are generally not a facility. So it could make sense to just broaden the that IGT language paragraph to have and providers, or and I don't know, some other words, but I think and providers probably would cover it.
You think and providers is better than and services, as providers more defined?
Services is fine as well. So I think either one would do the purpose. Just I agree that the point of facilities being, facilities period may not have been sufficient.
Okay. Any other questions on this? I think before we consider Senator Scott's amendments, we'll have to have a motion on the bill, but do we have any more public comment on the bill? Representative Barlow.
Thank you, Madam Chairman. So up underneath the definitions, there's a net revenue definition. And I guess to me, that is not what net revenue would be in a fiscal perspective, from a fiscal perspective. So I'd like both of the Erics or whoever to comment on whether that net revenue definition is actually net revenue or gross revenue. and whether that needs to be adjusted in some way. Thank you.
Any Eric?
Madam Chairman, we're both still here. I'm going to let Mr. Weatherford address that if that's okay. He's got the
You
expertise.
changed
on-
locations on my screen. Mr. Weatherford.
Thank you, Madam Chairman. That's a term of art that the federal government uses and healthcare providers typically use because gross revenues typically reflect their charges, which reflect a charge master, which may be different than the exact amounts they receive, because they may have a different negotiated rate with, say, Cigna than they do with Aetna. So net patient revenue is designed to reflect a different term, and it's the amount they actually receive. I think, when you think of net, most people kind of think of income, and maybe that's kind of where you're kind of coming from, like the amount that you receive after expenses. And that's kind of how I think about it anyway. But we're trying to use the definition that is reflected in the Code of Federal Regulations. It doesn't necessarily have to be exactly this. It does just have to be uniform. But this is what we've used in the hospital program. And so we're trying to be consistent.
Good. Okay. Do you hear a motion on the bill? So moved by Representative Dayton. Are you moving? I see your box lit up.
Yes,
Would you like to move the bill?
I would like to move the bill.
Okay, is there a second? Seconded by Chairman Scott. Okay, I believe Co-Chairman Scott has some amendments. Committee, if you will look in your inbox, you should have received this morning a document so you can just see it in typed form rather than verbally. Chairman Scott, do you want to go over them? You're on mute.
Madam Chairman, first one I'd like to do is the one on adding Medicare in here that got omitted. And what it would do would be to ensure that the providers are willing to take Medicare. And the one that was distributed, we intended to have this in to start with, but the one that was distributed reads ground ambulance service providers who provide ground ambulance services to Medicare beneficiaries. I would like to stop the amendment right there. I don't think we need the second sentence.
Co-Chairman Scott, I'm a little, okay, I'm looking at the page that was sent out. It says Senator Scott proposed. Where are you on that page, or what page of the bill are you on?
It was sent out earlier. This is.
Oh, okay, an earlier one, hang on.
Yeah.
I
will have to find it. LSO, can you give me a?
Yeah, Madam Chairman. I might check with either and see if they have different comments. Katie, maybe. This would be likely something that was delivered with our packet of materials. This was available and distributed at the end of last week. It's a separate document, but at the top would look like that with a request for Senator Scott and a more simple amendment.
Okay, I vaguely remember seeing this, but how do I find it now, Katie or someone?
Madam Chair, I'll send it to the committee shortly.
That would be helpful. Chairman Scott, while we're waiting for that to be resent again, just pick up on the one that went out this morning, if you would.
Madam Chairman.
Yeah.
The first one is on page 14. it would be on line 4, delete the and insert or. This is a technical correction. What goes on is we're asking that they be in network or have this alternative for anybody with a 20% market share, and you have the language would require a 20% market share in both. You've got some, at least one insurer that I know of that is a competitor in the small group market, but not in the individual market. And their market share is in the vicinity of 20%. So we need to allow the or so that either one of those qualifies, and say you've got to make an offer with them. So that's
Okay.
all that does.
Committee,
I'll
let's
move
do
that
these
one.
separately, just so that we can dispense with them and not have to circle back. So is there a
That's my
second to this
intention.
amendment? Seconded by Representative Sweeney. And is there any discussion? Okay, all in favor, please put up your hand. 1, 2, 3, 1, 5. Okay, that amendment passes. Okay, next one.
Madam Chairman, the second one is on page 2, line 14. There's some delete and insert.
Wait, Mr. Co-Chairman, are you sure it's not page 14, line 12?
Page 14, line 12. Did I say something? Yeah, I did. Page 14, line 12. What it would do is modify the start of that sentence to read, the offer provided by this subparagraph may be higher to the extent the ground air ambulance, and then goes on for the rest of the paragraph. It's essentially a clarifying and technical correction, so that if they can show that their costs are higher, they're not limited by twice Medicaid. There are some constitutional provisions that do govern utility regulation, and would govern this too, where you've got to give them the chance to say, no, it really does cost more than you're allowing. So that's what this does.
Okay, is there a second? I'm not seeing a hand. I'll second it. Any discussion of this?
Madam Chairman.
Mr. Co-Chairman.
Madam Chairman, as written, I found it quite confusing. The concept is a little confusing. What we've said is that you've got to be willing to make an offer of twice Medicare. It's conceivable that Medicare pays poorly enough so that is even twice Medicare doesn't cover your costs. You've got to give them an opportunity to recover the costs and have some opportunity for profit. Otherwise, there's a list of Supreme Court precedents a mile long in the really stemming out of electric utility and insurance rate and actually railroad regulations that says you've got to give them a chance to recover their costs when you're doing something like this. So that's what this does, is it says if you can prove that twice Medicare isn't enough, that's a reasonable offer.
Okay, just to be clear, Co-Chairman Scott, so you've stated Medicare, but the paragraph refers to Medicaid. Are you actually wanting it to be Medicare or Medicaid?
Double the, I didn't catch that. Double the, it's intended to be, no, it works either way, Madam Chairman. It's written as Medicaid. I said Medicare, but it works as Medicaid. That's a set rate. And if it's not adequate, you have to have the ability to say, look, I've got to charge my private people enough to pay the cost of what they're doing. So, yeah, it works as Medicaid too.
Okay. No questions on that one? Representative Yin.
Thank you, Madam Chairman. Yeah, so I'm still a little confused. I'm trying to interpret what the difference is between the new language and the amendment and the old language. The old amendment says that the subparagraph is satisfied even if, so does that mean they didn't make an offer and it's still satisfied as long as they prove that the costs are still higher than twice plus 6%? And then the new language still requires them to have the offer to satisfy the subparagraph. And maybe that's just confusion in the old language, which is why we're picking the new language, or why we're considering this amendment. So maybe a little more clarification, I think, from Mr. Scott. Thank you.
Good, Chairman Scott.
Madam Chairman, I had trouble understanding the old paragraph. And I knew what was intended. And the intent is to allow them to go more than twice if their costs justify it, and give them an out. They can go, the way it's intended is they can twice, if they're twice the rate, in this case, the Medicaid rate, we're saying that's reasonable, but frankly, the rates are low enough so that may not allow full cost recovery. You need to be able to allow full cost recovery. So this is saying, if you can prove that that's not full cost recovery, then you can go higher.
Okay, more questions? Okay, then we'll vote on the amendment to page 14, lines 12 through 14. Changing the language as in proposed. All in favor, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, any opposed? Some people aren't voting always. Okay, that amendment passed. Okay, Chairman Scott, I think we have done this one on page 15.
Page 15, line 20. And Madam Chairman, what this does is, if you look at G as it's written, I was a bit concerned that we might be using this language. I think it's needed for the feds because they want to make sure we aren't just taking their money to supplement our general fund. And we're going to cut this. I think we're going to cut the Medicaid program in general. And I suspect it will affect air ambulance. The coming session, Madam Chairman, really scares me as to what we might have to do financially. And that's one of the reasons the bills before us is, frankly, the Eric Squareds of the world were smart and tried to solve a problem that they could see coming. But we still have to satisfy the feds. And I would propose to add at the end of the sentence there on page 15, line 20, add the words, therefore the payment shall not be increased by any reductions in Medicaid rates. And Madam Chairman, I would ask your indulgence to ask Eric Boley and Eric Weatherford if they think that that would be helpful in dealing with the feds, or if we could safely leave that out and not get hung with something where we've blocked ourselves from doing what we're going to.
And Co-Chairman, I will just insert there, if they have any thoughts on the wording. I have to say, to my mind, it seems a little unclear that payment shall not be increased by any reduction. I mean, I don't, somehow it doesn't grammatically it doesn't make sense in my head how you can increase a payment by a reduction. If we're trying to say, therefore the payment shall not be increased to balance any reduction or something, it doesn't seem quite right. But go ahead, Eric Rowley or Mr. Weatherford.
Madam Chairman, I'm going to defer to the legal expertise of the other Eric.
The other Eric. Mr. Weatherford.
Madam Chairman, in looking at this, I don't know that we're replacing the money if it's appropriated, because once it's appropriated, it's appropriated. You're spending it. This is money on top of appropriated funds, as I understand it. And again, I'm not a legislator, but I would say that what we're doing is trying to supplement your appropriated dollars or any other Medicaid dollars, but this seems to me to be something on top of what you're doing. Even if you did cut Medicaid through your appropriations, we'd still be doing something on top of those appropriations, so we wouldn't be replacing them. If I'm understanding the question correct.
Madam Chairman,
Senator Scott.
what I'm concerned,
Oh, you just muted. Oh, there you go.
Madam Chairman, what I'm concerned about is that I don't want anything here that would preclude us from having to make a cut in the reduction, and it may be, Madam Chairman, this language doesn't quite work, because I think we are going to make a reduction, probably make it before we actually get this passed all the way into law, certainly before we would approach the feds. Madam Chairman, I think this amendment I'm going to think better of and not offer.
Who was it that seconded the amendment? I forgot. Maybe it was me. Okay, it's okay with me. All right, we'll put that on hold and let it percolate still a little bit longer. Can certainly bring it up during session. Okay, then we have page 19.
Madam Chairman.
Mr. Co-Chair.
On page 19, I thought that Mr. Springer had a useful suggestion there. So I want to accomplish with one motion both what Ian suggested earlier and what Mr. Springer had suggested. So I would move that on page 19, line 23, after the word facilities, we add the words "and providers" and delete the balance of the new language in that section.
Okay, do we have a second? Seconded by Senator Schuler. Okay, any discussion on this? Representative Barlow.
Madam Chairman, I think that if you're going to have "and facilities" at the end of that sentence, you also need it after the qualifying facilities or providers. I think you needed it in two places to make it consistent. Thank you, ma'am.
On line 20.
Yes, ma'am.
Okay. Senator Scott, is that okay with you?
Madam Chairman, yes, that's a good catch, friendly suggestion.
Senator Schuler, all right with the seconder? Okay, so the amendment then is, rather than the paper sent out to you on, by email, to on page 19, on line 20, after the word facilities, insert "and providers," and on line 23, after the word facilities, insert providers, and then strike all of the new language on the balance of page 19 and the beginning of page 20. We don't need any renumbering because we're keeping that in. Okay, any discussion on that? Okay, everybody, if you're in favor, anyone in favor of this amendment, please raise your hand in front of your face. 1, 2, 3, 4, 5, 6, 7, 8. Okay, any opposed? All right, that amendment passes. Okay, I think that is, oh, we received, if you will look in your inboxes now, you have received the other Scott amendment. You can pull that up and give yourself a double screen here. Okay, Senator Scott, do you want to go on? This one was on page 13.
13 after line 15.
All right, let's get there. Okay, page 13. After line 15, inserting a new section 2 and renumbering. Go ahead, Senator Scott.
Madam Chairman, I will move the amendment, but I will only move it through for the first, in my written copy, it's first 2 lines. 2 little I, ground ambulance service providers who provide ground ambulance services to Medicare beneficiaries. I don't think we really need the rest of it. If they're in business at all, they'll provide money. So just kept it a
Okay,
little simpler.
so your motion is inserting paragraph 2 that will say, and this is following, so you'll notice, committee, that this follows after, up at the beginning of paragraph C on line 5, we're saying these providers shall be eligible. And so then there's a list, 1, 2, and so on. So we are inserting ground ambulance service providers who provide ground ambulance services to Medicare beneficiaries, period, or semicolon rather. Is that correct?
Madam Chairman, that's correct.
Okay, is there a second? Seconded by Roscoe. Okay, any discussion?
Madam Chairman,
Senator Scott.
what this does is give us a complete list of the ones, does not include the ERISA exempt people. They're sort of outside of our control, but the saying if you're going to be a ground ambulance provider and participate, you've got to take Medicare, Medicaid, and try to get network with the private providers. It makes it a more complete thing, and it was what was intended originally. It just got omitted.
Okay, certainly living in Cheyenne, I think about TRICARE people, but I am not going to bother plugging that in. I'm sure it's covered by these other categories. Anyway, any further discussion? Okay, all in favor of this amendment, adding Medicare beneficiaries, please raise your hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, all right, there was nobody opposed. So that amendment passes. Okay.
Madam Chairman.
Mr. Shaw.
Thank you, Madam Chair. Just one question. Since consistent with that amendment, Chairman Scott, would you like then to amend the language in what is subparagraph 1 on that page to be the same? Because that includes the language that you just executed from your amendment.
Chairman Scott.
Chairman Scott, I think you're muted.
Yes, you're on mute, Chairman Scott.
Yeah, Madam Chairman, I would think that was appropriate that we give Ian the license to do that, get it consistently drafted.
I'm going to consider that a conforming amendment at the chairman's discretion. All right, so after beneficiaries, there will be a semicolon on line 12. Okay, Any other amendments to this bill? No, well then, LSO, would you, oh, Representative Barlow.
Madam Chairman, first, I assume there's no more public comment in general. My question is, and I want to make sure I'm clear about this, is the way I'm reading this is 104 says all ambulance providers have to participate. 5 says there's penalties, including loss of licensure if you don't participate. But 106 says if you don't do these certain things, you can't have access to the program. So what happens, if I'm reading this or understanding this correctly, what happens to the revenues that someone may have to put in, but then they don't qualify for payments? What happens to those revenues? They just sit there in the pot? Thank you, Madam Chairman. And maybe I'm misunderstanding how 4, 5, and 6 go together, but if I am, I'd like that pointed out. Thank you.
No, Representative Barlow, I think you, I did notice that last night because yes, we're taxing everybody, but if some people choose to be not provide in certain categories, they don't get any. That is quite correct. And I chatted with Senator Scott about that last night. So although I didn't ask him about what happened to the money. So Senator Scott, do you have any input on this?
Madam Chairman, my understanding, and Health Department could correct me if I'm wrong, is that then you'd have excess money carried over to the next period. You wouldn't need as big an assessment. But you see, the feds have insisted that our assessment have the character of a tax because they're essentially insisting that there be local public money to match their federal money. So it basically has to be a tax and those have to be uniformly assessed. That's why there's the provision in there that you can't expect to get back exactly what you put in. The whole thing is structured to have that division. So it is an incentive for everybody, the ambulance services, to provide the essential public services so they don't get there and say, oh, we can't take you because you're covered by Medicare, that sort of thing. And I think that's appropriate. And it is appropriate to have some division there between the tax, and feds insist on it, having a division between everybody's got to pay the tax, and then you don't equally get back what you put in.
I think that's a situation with most of our taxes, but you think of your own 1040. But yeah, certainly Representative Barlow, if we revisit the suspension of license, I could see that arising perhaps later. I feel your doubt on that, but we might save that for later. Any other, so I believe no other public testimony as far as I understood from LSO, and no other discussion from everybody? Evidently not. All right, LSO, please call the roll.
Madam Chairman, this is on 21 LSO 179 as amended. Senator Baldwin.
Aye.
Senator Bouchard.
Aye.
Senator Pappas.
Aye.
Senator Schuler.
Aye.
Representative Barlow.
Aye.
Representative Clem.
No.
Representative Dayton Selman.
Aye.
Representative Halliday.
Aye.
Representative Roscoe.
Aye.
Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Representative Yin.
Aye.
Co-Chairman Scott.
Aye.
Co-Chairman Wilson.
Aye.
Motion has been adopted.
Okay. I think we're generally putting off the discussion on which chamber will start which bill until we maybe get to the end of the interim and see what we've got. But Okay, on the agenda now, well, we're only 45 minutes behind. We will take our break and let's be back at 11:15. Okay, break until 11:15. And please make sure to mute your camera while you're gone so we don't have to hear everything that you do.
sounds like you kept people safe when they needed to be kept safe, so. They felt they needed to.
Oh, how come I'm not getting sound?
Oh, sorry, LSO, are we back?
Because it wasn't sound.
Yes, Madam Chair.
Okay, then we will pick up with the nurse practitioner compact. And looks like we will have that presented by Ms. Labonte from the State Board of Nursing. Welcome. Oh, you're muted. Dang those mute buttons. There you go. Oh, welcome. LSO, are we back?
Is that good?
We are back, and Ms. Labonte is about to present on the
Madam Chair.
nurse practitioner compact. And we will
Okay.
pick up with the nurse practitioner compact.
Right.
And looks like we will have that presented by Ms. Labonte from the State Board of Nursing.
Right.
Someone needs to mute their YouTube. Dang those mute buttons.
Okay, so how are we now? Is that good?
There you go. Oh, welcome.
Hi.
Also, are we back?
Is that
Someone is playing their YouTube at the same time. That needs to be turned off. Practitioner compact. Then we will pick up with the nurse practitioner compact.
Right.
And looks like we will have that presented by Ms. Labonte from the State Board of Nursing.
Right.
Someone needs to mute their YouTube. Dang those mute buttons.
Okay, so how are we now? Is that good?
There you go. Oh, welcome.
Hi.
Also, are we back?
Is that good?
Someone is. Okay, well, if people are playing YouTube at the same time, you need to turn that off. Board of Nursing. Right. Someone needs to mute their YouTube. Dang those mute buttons.
Ms. Labonte, you need
So
to mute your YouTube page in order for the committee to continue to hear you.
There you go. Oh, welcome.
Hi.
Okay, well, if people are playing YouTube at the same time, you need to turn that off. Board of Nursing. Right. Someone needs to mute their YouTube.
Ms. Labonte, you need to mute your YouTube page in order for the committee to continue to hear you.
Okay, and I thought I had done that, so. Can you pick that up?
Yeah.
please?
Well.
Or just close out of the YouTube browser, it'll turn it off.
Time, you need to turn that off.
How's that?
I'm afraid to talk.
How's that?
Better.
I think we're okay. I felt like we were taken over by the Borg for a moment there.
I'm so sorry. Can you hear me now?
I think we're good. Go ahead, Ms. Labonte.
I really thought I had DC'd that out. Anyway, thank you. So co-chairs Scott and Wilson, thank you so much for the opportunity to address you today and to the committee. My purpose in being here is to introduce the APRN compact to you, and these are the revisions that have been adopted by the Delegate Assembly at National Council State Boards of Nursing. But I'm Cynthia Labonte, the Executive Director of Wyoming State Board of Nursing. And I also have in the room with me Lori Hart, who's our new P&E consultant. And the purpose is to bring forth the revised APRN compact to repeal and replace the original APRN compact that was adopted in 2016. So the APRN compact that was originally adopted has not been adopted by more than 3 states, Idaho and North Dakota and Wyoming. We originally needed 10 states in order to be able to move that forward or for it to become effective. And we haven't gotten more than the 3 states. And so National Council State Boards of Nursing and the executive officers went back to the table. They convened a task force and they revised some of the language of the compact to make it more palatable for some of the other states that have APRN collaborative practice. So what I have provided for you, there are some APRN Compact key facts. There is the APRN Compact provisions, and then also the APRN Compact language as written. And what I want to discuss with you are the major changes, and then what are the benefits to the APRN Compact. So the major changes, the first one is that the number of states have been reduced from 10 to 7 in order to become active. We added uniform licensure requirements so that stakeholders would know exactly what is required for licensure. Then the item that is most contentious is the 2,080 practice hours under current state law. That is the item that has become most contentious. And you may hear others talk about that, but basically what it says is that an APRN who graduates from school must have 2,080 practice hours under their belt prior to being eligible for a multi-state APRN license. And that is 2,080 practice hours based on what is current state law. So in Wyoming, because our APRNs are independent practice, have independent practice authority, that means that that doesn't change. They would simply need to do their 2,080 practice hours before they would be eligible for a multi-state license. In other states, like Virginia, as an example, they have something called collaborative practice or transition to practice. And it's almost 10,000 hours where an APRN who grads must be with a collaborative partner or a peer, often a physician, in order for 10,000 hours, which is almost 5 years. If Virginia adopted the compact, then the APRN would work for 2,080 hours or practice under the current state law in Virginia, which is collaborative practice. At the end of that time frame, the 2,080 hours, then they would be eligible for a multi-state license, and the compact overrides state law, and that APRN would work independently in all other compact states. In Wyoming, again, it does not change APRN practice. They will still practice independently, but they have to have those 2,080 practice hours under their belt. And the addition of the hours was an attempt to provide some accommodation to those states with privilege or transition to practice hours. In Wyoming, our statistics show us that 95% of all APRNs would be eligible for a multi-state license tomorrow. So this really affects just the new grads in Wyoming. Across the nation, 92% of all APRNs would be eligible for a multi-state license. So it really does affect just a very small number of Wyoming graduates.
Ms. Labonte, if I can just I just want to clarify something there. So, not that I really need to know necessarily about nurses in Virginia, but so you were saying that an APRN in Virginia needed 10,000 and some hours, but after 2,080, they would be eligible for a compact license. So now I would assume, though, that they would only be able to practice in states that had a 2,080 hour requirement in their own state or fewer hours. I mean, or are you, I mean, I'm assuming that like a Wyoming licensee with only 2,080 hours, in other words, a new graduate, would not under the compact be able to practice in Virginia beyond what they're, I mean, that's not what you're saying, is it?
No, this is, the premise is that APRN, after getting their multi-state license, can practice in any other compact state. So that state would have to adopt the APRN compact. And after
if the state currently requires 10,000 hours, are you saying that a nurse who gets a license under the compact could go into that state with a compact license and work with 8,000 fewer hours than people in that state who only have that state's license?
Yes. Once you have a multi-state license issued by your home state, then you are able to go into any other APRN compact state and work as with independent authority.
Even if nurses who are licensed in a single state cannot?
That is correct, because you have a multi-state license that allows you to do that.
Okay, go ahead. Thank you.
Co-Chairman Scott?
Oh,
Madam
sorry,
Chairman.
Co-Chairman Scott, didn't see your hand.
Sorry, Madam Chair.
Co-Chairman Scott, go ahead.
Yeah, Madam Chairman, just wanted to clarify on that point. Basically, am I right in understanding that a Wyoming licensure would start the same way as it always has? You'd meet the same criteria. And then after you've been in practice for a year, then the APRN could apply for a multi-state license and then be able to say they decide they want to be a traveling nurse, could go to the other compact states without further licensure.
Yes.
But it would not affect our initial licensure, and somebody who didn't yet meet or couldn't meet the multi-state requirements would still be able to be licensed here in Wyoming.
Yes. They can have a single state license. And the APRN compact license is an option. Not everybody's required to have one. I don't have a multi-state license as an RN because I don't need one. But in this particular case, yes, an APRN continues to practice as they do with independent authority in Wyoming. If they want a multi-state and they met the requirements, they could apply for a multi-state license. Yeah, thank you. You got it.
Okay, go ahead, Ms. Labonte.
All right, thank you. So what are the benefits to the APRN compact? And just as with our RNs and our LPNs who are under our NLC compact, it's access to care. It provides greater flexibility for APRNs, and patients are able to get that care. Telehealth. During COVID-19, we had a number of APRNs who called us and they wanted to initiate or engage in telehealth with patients in Wyoming. Because we initiated the emergency law that we have in place, we allowed any licensee with an active, unencumbered license to practice in Wyoming on a license from another state. We had a lot of APRNs who engaged in telehealth with, say, a California license. They did not have to get licensed in Wyoming just during this emergency COVID-19. So but you have to have a declaration of emergency in order to activate that law. So if you had the APRN compact, that would already be in place and you would have that flexibility already there. So those APRNs would be able to move back and forth as needed. The other thing it's good for is, or benefit is for military families. An APRN who gets reassigned and to a new town country is able to practice under that APRN compact license. Gets them back to work more quickly. It's also cost effective. It would require an APRN to only hold one multi-state license, and then they can function in any other compact state. Right now, I have spoken with at least 2 APRNs. One has, and they're Wyoming APRNs, one has 6 licenses, including one Wyoming. And APRN licenses probably run anywhere from $500 to $1,000 a piece. And then I spoke with another APRN who has 7 different licenses in other states. So they really like that opportunity that they would only need to have one multi-state license. The other part is flexible licensure. As I mentioned, it is optional. If you want one, you can apply for one if you meet the requirements. If not, then you would still be able to function as an APRN under a single state license. So I think those are, I've talked about purpose, I've talked about the major changes, and I've talked about benefits. I'm hoping I've provided enough information for you to be able to make a decision. We do need to repeal and replace the current APRN compact. And so I would like to move it forward into the 21 legislative session. Thank you.
Okay, more questions. Senator Bouchard.
Thank you, Madam Chair. I went and looked at the current map that shows the states that have already advanced such proposal here, there's zero. I'm really concerned. I mean, I think that the states around us, I'd want the conversation of the reciprocity around us already. And I just look at the time that we spend on bills. I just don't know if this is ready for prime time to advance such a thing. So what's the, I guess my question is, there's no states that have done it. Why would we be the first?
Ms.
Well,
Labonte?
thank you, Chairman Wilson. I guess why not be the first? We were the first to adopt the original APRN compact. And the reason you haven't seen any movement yet is because this was just adopted by the Delegate Assembly of National Council State Boards of Nursing in August. So we are just getting it out rolling and getting it out to our boards of nursing, as well as to the stakeholders across the country. Most of the states, and with COVID, are not in legislative session right now. And so most of your activity will occur next January, February, March.
Questions for Ms. Labonte, Senator Bouchard?
Thank you, Madam Chair. Isn't there a federal law that is being looked at to allow to fix the problem, to make it more permanent than what we have with some of the temporary things that came in COVID? Isn't that a better possibility than this compact?
Ms. Labonte?
Thank you, Madam Chair. I believe you're talking about the TREAT Act. And if you want to maintain state rights and state rule, then you're better to have a state compact rather than a federally driven initiative.
More questions for Ms. Labonte? Representative Sweeney.
Thank you, Madam Chairman. My question, Madam Chairman, is I didn't receive one positive comment or one positive thing on moving forward with this. You mentioned stakeholders across the country, but what about right here in Wyoming? Has the Board of Nursing actually reached out to our stakeholders who are objecting to this?
Ms. Labonte?
Madam Chair, thank you. I have spoken to several individuals, and I understand that there is opposition. However, I do have a communication plan that I will put into place in order to communicate and educate stakeholders in Wyoming about the compact.
Ms. Labonte, if you'll just remind me, the signers of the current compact are who? Us, Idaho, or remind me who they are?
North Dakota.
Wyoming, Idaho, and North Dakota. So have you talked to, and I appreciate that this just came out in August, so that hasn't given you a ton of time, but what is your feeling as far as acquiring more states? I mean, obviously that's certainly the goal of the compact, is to have a lot of states. What's your discussion been with other boards of nursing?
Madam Chair, thank you for that opportunity. I have spoken with both Idaho and North Dakota. In Idaho, the governor is in full support of the compact, and they are moving forward with legislation in 21. I have spoken with North Dakota. They are also moving forward with legislation in 21. And she believed at this time, she's communicating with the Advanced Practice Nurse Association there, that they will be supportive. The Advanced Practice Nurse Association in Idaho is also supportive of the compact in Idaho. In terms of other states, the original compact limits, because of the independent authority piece, limits the possibility of adoption to about 14 states. With the addition of the practice hours, the 2080 practice hours, it's more palatable to those states that have the transition to practice hours. And so you can add about 20, there are now about 24 states that would be able to adopt this compact based on the new language. And it's also my understanding, Madam Chair, that several of those will move it into legislation is their intent. I don't have the exact names of those states, but is their intent to move it forward to legislation. So Senator Bouchard, that is why you're seeing no activity at this time on the map. I've seen that map as well. It looks alarming, I get it. However, though, we're just moving into the action and the education and into legislative sessions come 21.
Okay, more questions, Senator Scott.
Madam Chairman, I did get some contact from people in this field, particularly former member of the legislature. And the concern was that this compact would restrict, it really is twofold. Mostly they was concerned it would restrict our current practice abilities, which we're quite broad in our ability to practice. You know, the APRN can prescribe, they can practice independent of a physician, and the concern was that this compact might change some of that. And there was, I think, a secondary concern that it might put some additional requirements on getting licensed in that they don't have. My thought was I can't find anything in here that I think does restrict it. But my thought was that implementing it, we would put in an additional line or two in our statute that nothing in this was to be construed as restricting the existing practice of nursing and of advanced practice nursing in this state. And my question is twofold. One, Ms. Labonte thinks that would be helpful. And am I right in saying that there isn't anything additionally restrictive? And when I looked at the list on page 4 and 5, it did seem to me that the hours thing is new, but as I understand, that won't restrict your ability to get licensed in the state. There's also, I suspect, the provision number 9 on a felony. I suspect we've treated that a little differently in this state. Is there anything else in here that will make it more difficult to get licensed in this state?
Ms. Labonte.
Madam Chair, thank you. Senator Scott, great questions. Regarding number 1, this compact does not change the independent practice authority that an APRN can engage in Wyoming. So I don't know where that came from, but that, again, it does not restrict practice for the APRN. In terms of number 2, the felony piece. The felony is treated the very same as we do for the RNs and LPNs. Essentially, we have very few RNs and LPNs who have engaged in felonious activity, I think that's the word, and are licensed. But even any individual who has a felony, they're precluded from a multi-state license, but they can still have a single state license. So it doesn't preclude them from practice, it just precludes them from getting a multi-state license. And it has to be pretty awful felony to not get a license. And we see very few of those.
More questions for Ms. Labonte? Representative Roscoe.
Thank you, Madam Chairman. Ms. Labonte, why is there a limit on, why is there a requirement, I mean, for the changing to 7 states? Why couldn't it just be the 2 that we already have? Is it just a administrative cost or what? Thank you.
Ms. Labonte.
Chairman Wilson and Representative Roscoe, thank you. if there are 3 states and we, 3 of us, the executive officers of the boards of nursing of the 3 states that adopted the APRN compact talked about just having a trial run on the compact. However, that wasn't seen favorably by the other executive officers. The reason I believe is that it really, you want to be able to give APRNs flexibility to move amongst different states. I mean, that's what it's all about, is to be able to move on a dime, essentially. And if you only have 3 states, it's really not enough. 10 seem to be too many. The task force launched on 7, thinking that would be an appropriate number to get it started. 3 didn't seem to be enough.
Thank you, Madam Chairman.
Although clearly Wyoming, Idaho, and North Dakota are the best states, so I don't know why anyone would want to practice anywhere else. Okay, before we open to public comment, if I can just ask LSO, Ian or John, does the material that we have in this suffice for you to, if we were to go forward, draft up a new compact bill for us to consider in November?
Madam Chairman, John Brody, LSO. I believe so. I would just ask, I mean, compact language, there's not much flexibility that you can do, certainly. But for my review, I think we're in a secure place.
Okay, good. Well, then let's, Elizabeth, we can go to public comment. I think there are probably some people waiting.
There are quite a few individuals, ma'am. First,
All right.
we've let in Wesley Davis. Would you like us to admit all the individuals at once or one at a time?
You know, why don't you just put them in one at a time so I don't have to try to decide which one showed up first?
Perfect.
Mr. Davis, or Dr. Davis, I believe it is, if I recall. Welcome. Can you hear us?
Yes, I can. Can you hear me?
We can hear you. Go right ahead.
So good morning, Chairman Wilson and Chairman Scott and members of the committee. My name is Dr. Wesley Davis. I'm a nurse practitioner here in Wyoming, and I'm delivering this testimony today on behalf of the Wyoming Council for Advanced Practice Nurses. I have the honor of serving as the president of the council and representing Wyoming's approximately 1,000 APRNs in this capacity. This morning, I come before you to express the council's opposition to the APRN compact for multi-state licensure model legislation that was discussed just prior by the Wyoming Board of Nursing. In particular, we are concerned with the provision that requires the 2,080 hours of postgraduate practice for the advanced practice registered nurse. It is our view that this compact, if it's adopted in Wyoming, it will create new barriers to practice for nurse practitioners by subjecting Wyoming to the outdated laws that are still in place in other states. As a consequence, a more limited supply of APRNs would threaten Wyoming's residents' ability to access the healthcare that they need. So despite the good intentions of the National Council of State Boards of Nursing in developing this proposal, and the Wyoming Board of Nursing in bringing it before you today, the inclusion of the 2,080-hour requirement runs counter to the recommendations of nursing organizations in Wyoming and nationally that represent nurses and other healthcare professionals. I think we're all aware that decades of research and evidence demonstrate that APRNs who graduate from an accredited program and pass the board certification are sufficiently prepared to provide safe and quality care. So it's this reason that we as the council stand with groups like the American Nurses Association, the American Association of Nurse Practitioners, and the National Association of Pediatric Nurse Practitioners, to name a few, in opposing this APRN compact as it is presented today. The council has heard similar concerns from the nurse practitioner community here in Wyoming. Moreover, Wyoming's nurse practitioners are concerned about adopting a compact that would impose barriers to health care that Wyoming superseded a long time ago. As one of my members put it, quote, one of the root problems of the APRN compact is that it approaches all states as if their APRN practice laws are the same, end quote. In Wyoming, we've already established a licensure system that works for us, and in many ways, adopting the compact would mean adopting the regulatory requirements of other states. Doing this would move us backward. This last point is important not only for nursing professionals, but indeed for all of Wyoming. New barriers to entry into the profession will limit the ability of Wyoming's residents to access care. Because the state has a small number of healthcare providers, many communities across the state increasingly rely on nurse practitioners for care. So the new requirements would make it more difficult for advanced practice registered nurses to operate with a multi-state license, and as a result, make access to high quality, affordable providers more scarce. So with these objections in mind, the council expresses a sincere hope that the committee will decline to take up the model legislation in its next session. The council is committed to working with you and the rest of the healthcare community to develop policies that maintain high standards for nursing practice while ensuring that Wyoming residents have access to high quality and affordable healthcare in every community. Co-Chairman Wilson and Chairman Scott and members of the committee, thank you for your time and consideration.
Questions for Dr. Davis? Chairman Scott.
Madam Chairman, I think this gets to the root of what I've been hearing. As I read this, I don't see any change in the licensure requirements in the state. You can do that exactly the way we're doing right now. All this does is say if you want to get a multi-state license, then you have to have been, and the key issue seems to be the year's worth of practice, the 2,000 plus hours. And I don't see how that, my understanding is that doesn't affect the licensure in this single state at all. It just means that to move to be able to work in another state, you've got to have a year's experience here under your belt. Am I missing something here? Or is the association misreading this as saying this whole list then would apply to new licensure in the state, which I think it does not?
Dr. Davis.
Madam Chairman and Chairman Scott. So I'll use the quote from the Board of Nursing, and the quote was that the goal of this was basically to make it more palatable for states that have APRN collaborative practice. And again, I reinforce the fact that we're adopting a compact that has been modified from our previous adoption to appease other states that have these restrictive barriers to practice. So again, yes, I agree that it will not change licensure for a single state license, but we have a lot of border states. For example, the town that I work in Sundance, we have nurse practitioners that cross state lines. During their first year of practice, it would force them to stay in their home state unless they got a Wyoming license. So I think that what we have adopted already, the prior compact, is what we needed. So modifying these hours to make it more palatable to states that have restrictive practice is not the direction that we want to take Wyoming.
More questions for Dr. Davis? Senator Bouchard.
Thank you, Madam Chairwoman. What I'm looking at is a map, and it looks like most of the Western states, except for California, Texas, Oklahoma, Kansas, and maybe even Utah, are restrictive, but most of the states around us look good. And so I don't know the numbers. I tried to find the hour differences, but it really looks like, and so I need to be corrected if I'm wrong, it looks like it's easy to practice in all these green states, but if we do this compact, it would bring a further restriction in that isn't there now, and that's the main concern. Am I correct with that assessment?
Dr. Davis.
Madam Chairman and Representative Bouchard, yes, you are correct. In essence, if you have a single state licensure, and Mrs. Labonte may be able to correct me, but the single state licensure in those green states, as we know them, those are full practice authority states, would remain the same. However, the compact license is what would require the 2,080 hours. So yes, you are correct. That map does show the green states with full practice authority, and the majority of those have no transition to practice hours. The compact would introduce those 2,080 hours in order to get a compact license.
More questions for Dr. Davis? Okay, and Ms. Labonte, I'll let you sort of do a little wrap up at the end of the public comment if you've got some comments that you want to put in. Or Dr. Davis, thanks very much, and thanks for taking care of your folks up in Sundance.
Thank you.
Okay, Elizabeth, who's next?
Next, we have Dr. Kidner. I will let them in now.
Okay. Dr. Kidner, are you in Lander?
I am in Lander.
Welcome temporarily to the airwaves above Cheyenne. Go ahead.
Thank you. Thank you, Madam Chairman Wilson and Co-Chairman Scott. And thank you to all the committee members for the opportunity to provide comments on the APR and Compact today. I am Dr. Maria Kidner, and I graduated from CWC in 1987 with my first nursing degree. And I've been a nurse practitioner in Wyoming since 2001. I'm also an adjunct faculty member for Duke University, where I instruct future nurse practitioners from around the country. And I currently serve on the American Association of Nurse Practitioner Board of Directors. I am here today to represent the American Association of Nurse Practitioners and our members who represent nearly 40% of Wyoming's nurse practitioners workforce. On the behalf of the Wyoming Nurse Practitioner Committee, I respectfully ask that this committee not advance a bill to adopt the 2020 revised APRN Compact. While Wyoming has been a long trailblazer and leading of innovative policy solutions, our state has also been quick to realize how unnecessary regulations can have a disproportionate impact to our small state. For more than 40 years, Wyoming has recognized the value of nurse practitioners, and since 2004, a full practice authority state with 0 transition to practice hours or collaboration agreements. The ability for the APNs to help address these unique challenges in bringing healthcare to rural and frontier areas of our state remains critical to all of our citizens. Today, Wyoming, along with more than a dozen other states, license NPs at full practice after completing a nationally accredited graduated degree and passing a national certification exam. This licensure model provides Wyoming residents with full and direct access to nurse practitioner provided care and provides the state a favorable position to recruit and retain nurse practitioners. Our state was the first to adopt the second version of the APRN Compact in 2016. I'm proud of that bill, and I worked hard to make it to be a reality. That version of the APRN Compact mirrored our existing state licensure model and held the promise to end the patchwork of licensures and practice authorization to improve access to care and address provider workforce in the need of our state. However, this third version of the APR Compact that you are being asked to consider is not endorsed by the nurse practitioner community. The Wyoming nurse practitioner licensees were not ever informed by the Wyoming Board of Nursing that they intended to bring this request to you this year. This third version of the APR Compact, as you've heard, adds burdensome and unnecessary practice hours before an APN can obtain multi-state licensures. This required 2080 hours of work directly conflicts with the APRN consensus model. That is the national model for advanced practice nursing regulation that Wyoming adopted and the decades of research around safe practice for nurse practitioners. This APN compact is more restrictive for full practice authority than the existing Wyoming law for state licensures. Not only is it unnecessary for safe practice care, but it also creates a new bureaucratic cost and regulate to track nurse practitioners on two tracks. The first would be for your APRN Wyoming license. The second would be for a multi-state. So someone has to track 20/80 hours. Additionally, we are further concerned because the compact is not just about how the law impacts NPs who are licensed today, the 92% that Cynthia Labonte talked about. Legislation and the hard work that you do every day is inherently about the future. The revised compact impacts how Wyoming can cultivate and grow and use the APRN workforce currently in the education pipeline. Given our retirement forecast of Wyoming, ensuring that we have full capacity and the benefit of our APN healthcare workforce from day one of their profession practice remains vitally important to Wyoming. Given the role and growth of telehealth to reach our frontier and more remote residents, getting the compact licensure right without unnecessary restrictions takes on even a more importance. We respectively request the committee not move forward with adopting the revised APRN compact. There is no need to rush. Wyoming is not missing out. No other state has adopted this revised version. And importantly, the Wyoming Board of Nursing is doing an excellent job in processing the licensee's request in a timely manner from NPUs who live in our state and the states who serve our community via telehealth and outside our state borders. We all want the same thing, a healthy and robust and vital community in competitive Wyoming. We get there when our laws support growth and innovation and pull us forward without adding additional barriers that limit the ability to practice to one's full scope after graduating from a nationally accredited APRN graduate program, fulfilling a national accredited hours for clinical placement, passing a national examination board, and meeting the state's licensure requirement. For that reason, and the reasons that have been shared by the Practicing Nursing Committee, please do not advance this revised APRN compact. Thank you for your time, and I'm open to any questions.
Thank you, Dr. Kidner. Questions for Dr. Kidner? Chairman Scott.
Madam Chairman, seems to me that if we choose not to go forward this compact, the other compact has not succeeded in getting enough states. It doesn't look like it's going to go into effect. And we'd then be just stuck with the current system of you've got to come and get a separate license in each state, all that expense. My question for the APRN community is, would you support a law that without benefit of compact allowed APRNs from full practice states to practice here based on their home state licensure rather than get a separate license in the state? Would that be the approach we should adopt? Because it doesn't look like the original compact is selling.
Dr. Kidner.
Thank you, Madam Chairman and Co-Chairman Scott, for that question. You are most right in saying that it has been a difficult sell for the states to consider a compact license based upon full practice authority, restricted authority, and states with severe collaboration practices. That's why there's only been 3 in the last 4 years, and they had a drop from 10 states to 7 states. So currently, there is no guarantee that you will have states that continue to approve and consider this compact as it is. The 20/80 hours places a barrier for having states become full practice authority. Such in Colorado, they had a 4,000 hour as a compromise to bringing full practice authority. Then they had to go back to legislation and drop it to 2080, go back to legislation again and drop it down. And they are still trying to go for full practice authority without transition to practice or collaborative practice hours. Those hours are adding costs to providers, adding costs to the person who is required to do them, not changing safe care practiced in any way, and adding barriers. If Wyoming becomes the first, they set a precedence that full practice authority states believe that 20/80 hours is a good deal, and that nurse practitioners should work 28 hours in their home state. And it sets the process of removing full practice authority and returning to a collaborative practice paradigm. In addition, if a nurse practitioner, say they live in Nebraska and they have thought about coming to Wyoming to start their practice, but now have to spend a year, they will be in another state setting up their practice. And at the end of that year, it becomes highly unlikely that they will want to resettle and go through the process of initiating a new practice. So we will create a barrier of decreasing the ability for APNs to come to Wyoming to begin their practice. So overall, we are not missing out if you do not bring this legislation forward. I believe that the correct compact will come about, and there just needs to be a relationship between the National Council of State Board of Nursing and the Advanced Practice Program. In addition, this compact eliminated the request from the nurse practitioner communities to have an advanced practice advisory committee. This advisory committee was to be for the compact states to allow advanced practice nurses to be able to provide guidance and mentorship, because many of the states are being implemented without an advanced practice executive director or input. So people are making decisions on our practice and our ability to improve access to care and provide safe, high quality practice without knowing what an advanced practice nurse does. That advisory committee also got removed from the compact because the NCSBN did not think that that would be approved. So there are many other aspects to this compact that we do not approve of. And we hope that you will hit the pause button and not approve this in the current form and look at it once the form has been changed. Thank you.
So Dr. Kidner, though, following on what Co-Chairman Scott asked, and I'm not sure, I've pulled up a map that maybe Senator Bouchard was looking at, but it's kind of hard to detect about hours. Would it be helpful and cheaper for advanced practice nurses who maybe do want more than one state license if we had actually just not a compact, but a Wyoming state license that authorized some sort of expeditious, less expensive process for full practice, no hour states to accept the licenses of others? You know, you did say that the nursing board is doing a good job of processing them, but I just want to be clear, is a law along those lines something that would be considered of interest or not?
Madam Chairman, one of the questions that I would have to go back and ask would be, why didn't all of the full practice authority states jump onto the last compact? Because only 3 states did. And there were some concerns within that compact of full practice authority and how the compact was going to be implemented. If you ask the question, could Wyoming have its own multi-state access? That would be a process from the State Board of Nursing. And you would be developing like a state multi-license, an interstate of a small group. Montana will have already voiced an opinion that they will not join a compact. Idaho has also, from our references, will not be looking to endorse this current plan. North Dakota has done the last one and uncertain of its status at this time. So I'm uncertain if you open it up to full practice authority, if you would still get states that would want to do that. So I'm not sure, because they didn't apply this time, if really, is it the cost? Is it the process? Many who work in like telemedicine don't always have, their costs are paid for by their employer. So I'm not sure if that's the true barrier. The barrier here is that this compact is creating additional barriers for the United States.
Okay. Any other questions for Dr. Kidner? Senator Pappas.
Yeah, thank you. I do have a question for Dr. Kidner. First of all, Maria, it's good to see you again. It's been a long time. You'll have to tell Martin hello for us. Sorry you moved to Lander. For us, it's a loss for us, but I'm sure it's great for you. I really do want to someday find out about your biosensored telehealth process that's bringing cardiology to remote Wyoming. I think that's good. So good for you. But I do have one question. You know, I've always been supportive of compacts, and I've shepherded some through the legislature, and I voted for this one in 2016. But on most compacts, you know, typically the practitioners are behind it. I see on this one, at least to my knowledge, that there are a lot of folks, the American Nurses Association, the American Association of Nurse Practitioners, and the WNA, the WCN, CAPN, and the AMA even are all opposed to this. And the question is, are they all opposed for the same reason, the 2,080 hours, or are they just opposed with a thought of having a full practice authority with no hours? Because is there a median in there that the folks who drafted the compact could come up with if there were fewer hours? Or are we just looking at just a full FPA as we have it now?
Dr. Kidner.
Madam Chairman and Senator Pappas, it's good to see you too. Thank you. This bill this compact is opposed by several committees that you have already discussed. The American Nurses Association and the AANP, American Association of Nurse Practitioners, the NP Roundtable, the education and NP education groups, the NP pediatric groups, and the Wyoming Nurses Association, the Wyoming Council of Advanced Practice Nurses. We oppose this for two main reasons. The first is 2080 hours. Although, as you're sitting in Wyoming going, it doesn't matter because you're full practice authority from day one. That is true. We are full practice authority, but 2080 hours is placing a restriction upon people. It's essentially saying in the United States, you're okay in Wyoming to practice safe, high quality care in Wyoming, but you need 2080 hours to prove that you are safe and effective in any other state. And that's what we don't believe. We believe if we're safe in Wyoming, we are safe and effective in any state that we'd work in. The same with other states who are trying to become full practice authority like you mentioned, Senator Pappas. The goal is to reduce barriers, to improve access to care to every person in the United States. One highly effective way to do that is to look at the research and understand that nurse practitioners can provide that. And in doing so, that would be full practice authority. So you asked about the number of hours, where could there be a median? That median is 0. 0 hours is what will get support from the National Association, because we believe that we are providing safe and high quality care from day one when we meet all the accreditation and licensure. So the answer for transition hours or practice hours or whatever you want to call it is 0. So you did ask, are there different organizations and do we have the full one? In all honesty, I'll have to say the American Medical Association, the AMA, may have a different agenda and why they oppose having a large compact license that eventually, when done right and correctly, will improve access across the United States. And they oppose it for that reason, is that nurse practitioners would be able to provide high quality practice across the United States. So yes, there is a different agenda. If you wanted to ask overall for the advanced practice program, the second reason that we have difficulty is there's no APRN advisory committee in this compact. And because of that, there are people who are determining processes and regulations and rules without understanding the full scope and breadth and depth and possibility of APRNs in Wyoming and throughout the United States. So those are the two main reasons why we oppose it. There is some other wording that is on scheduling and the ability to provide prescription management, which is also tucked in this compact, that provides some heartburn for our national associations. Thank you for the question, Senator Pappas.
Okay, Senator Bouchard.
Thank you, Madam Chairman. I have something that I want to look at, and I'm looking at the map, and I look at Texas, which looks like it has a lot of restrictions. But under our, and correct me if I'm wrong, but the way I view this is we look at one of the underserved areas that we've had problems with before is in Department of Corrections. So and I did look, there are openings in Wyoming. So if we had someone that wanted to transition from a Texas correctional system and possibly retain their residence in Texas while they came up for some time, it looks like we can accept them very easily. But however, under the compact, we would change that. So if they were actually working in a prison for a year in Texas, for let's say 15 hours a week, but they did serve for, they did a year of employment under that structure, they could not come to Wyoming under the compact. So that concerns me. Again, correct me if I'm wrong, but that's the way I'm seeing this.
Dr. Kidner.
Madam Chairman and Senator Bouchard, so the clarity, the map that you're looking at is the authority map that is provided. So full practice authority, restricted authority, and collaborative practice. So it's the red, yellow, and green map. Yes. So the difference is compact states would be held within the compact licensing. So that those rules and regulations of trans going across state line would be for those in the compact, which were only 3 states, Idaho, North Dakota, and Wyoming. Who is going to be in the next compact? We hope the next compact will be revised and not this one that you're looking at today. And then we could have those people cross the state line. So currently, if I want to practice in another state and that's where my workplace is going to be, I would apply to that state board of nursing for an advanced practice license. Then I have to practice within their scope of practice. So if I went to Texas, I would have to practice not as full practice authority, but I would practice within their regulations of the state board of nursing. If someone from Texas decided to come to Wyoming to practice and they are eligible for an advanced practice license, they can receive a Wyoming advanced practice license, and they practice under the rules and regulations developed by the Wyoming State Board of Nursing and the scope of practice that was granted by you, the legislators, for full practice authority in Wyoming. So I think that there's a crossover. You're looking at a map of authority that's currently granted by each state, and the compact would be compact states that would allow people to cross the state license.
Okay, Senator Bouchard, I'll call you again, but committee members remember this. So the original bill potential is presented by the Board of Nursing, and we're hearing public testimony on the bill. So let's just make sure we don't get too far afield and start asking about nurse practicing. I guess that's not the word, but I mean, just make sure that we're not getting too far abroad here on asking the witnesses to testify beyond where they originally were. Senator Bouchard.
Thank you, Madam Chairman. I think I guess I didn't have the hypothetical that I was thinking of is that Texas and Wyoming would be in the same compact if they chose. And I would look at that as being more restrictive if someone was going to come in from Texas and practice in for instance, a correctional setting. They would have to fulfill those hours, whereas now they would not have to. That's kind of where I was going with my hypothetical. So I'm worried that we're going to create even more of a problem with Department of Corrections not being able to bring people in and fill these positions that we seem to have a problem with already. So that was my mindset.
Very good. Any more questions for Dr. Kidner? Okay, Elizabeth, who have we got up next?
Next, ma'am, we
Thank you,
have
Dr. Kidner.
Tony Declever.
All right, Ms. Declever. Ms. Declever, welcome. You're muted at present, but we invite you in.
Thank you, Madam Chairman, members of the committee, Tony Declever with the Wyoming Nurses Association. And I will be very brief and just letting you know that, as Senator Pappas mentioned, the board decided, the Wyoming Nurses Association board decided to stand with our advanced nurse practitioner colleagues and oppose this compact from moving forward. And for all of the reasons that have already been stated, I think that Maria did a wonderful job with explaining the reasons for their opposition. And just wanted to let you know that the WNA board stands in support of the nurse practitioners in opposing this.
Okay, questions for Ms. Declever. Representative Barlow.
Thank you, Madam Chairman. So does the board of or the organization still support the currently adopted compact? Thank you.
Ms. Declever.
Representative Barlow, Madam Chair, we are not opposed to compacts, and the old compact, if it had gotten the number of states that it needed to move forward, we would not be having this discussion. So we did support the old compact and what was in it, but now they've changed the language, and we don't support the language in the new compact. So if the folks at National Council of State Boards of Nursing were to go back and revise the language again, then, and where it would be more supportive on the nurse practitioner side, then we would support that.
Okay.
Did that answer your question, Representative Barlow?
more questions for Ms. Declever? Okay, great. Thanks very much, Tony. Elizabeth, who's next?
Next, we have Miss Lepard.
All right. Let her in. Ms. Lepard, welcome. Introduce yourself if you please, and let us know who you are and what you have to tell us. And what organization you're from, and you're still muted. Ms. Lepard, are you there? Can you hear us? Can you unmute yourself? There you
I
go.
do hear you. I'm being over.
Your technology is fighting back. Oh, you've just muted yourself again. Doesn't look like I'm able to unmute you for you, so there you go. Okay, don't touch anything. Back away, put your hands in the air. No. Okay, Ms. Lepard, if you'll introduce yourself, please.
I am sorry. I am being. There we go. How are you? I'm Alicia Lepard. My Zoom was still having Tony on, so I apologize. Madam Chairman, Chairman Scott, members of this board, I'm Alicia Lepard from Gillette, Wyoming. I own High Desert Healthcare. I am an APRN, not only in Wyoming, but I also share licensure with South Dakota, Montana, Colorado, and Nevada. And I thank you for this opportunity today. I stand here conflicted on this topic. I have argued both sides with all groups, and I see both sides of this story very clearly. To support my APRNs, I totally agree with the fact that this version of the compact is not adequate and does not support what the APRNs need nor wanted. And NCSBN was advised of that multiple times by our state representatives, and voted for this compact in August in opposition. I can't change their viewpoint. It was done in hopes that more states would adopt the compact. I've talked to our members, and there's no evidence to support that, to be very honest. I've asked them to show me if there are any letters of support that more states would come on board, and they say there are verbal discussions that indicate it might be moved forward. On the other hand, I'm cognizant of the fact that the statute, when we placed it in 2016 and signed into law, is now obsolete because the previous version doesn't exist. So we have a conundrum on our hand. Supposedly, approximately 24 states would then be eligible. I'd suspect it will be a long, drawn-out process, much as the previous one is. I perform telehealth across multiple states. I'm a national disaster provider under federal regulations and work with a wide variety of APRNs. I often pay greater than $3,000 to $5,000 every renewal period, which is every year for me, given the different licensing statutes. I'm sort of for this. I'm philosophically opposed to it. I just don't want it the way it currently reads. And so I would echo my colleagues in saying this is not the year for us to push this forward. We need to sit on it. We need to see what the other states are going to do as far as adopting it, and then reconsider if NCSBN will ever remodel it in the very near future. Thank you for this opportunity.
Good. Thanks. For any questions for Ms. or Dr. Lepard? Okay, thanks very much.
Thank you.
Elizabeth, who have we got next?
Next, ma'am, we have Christina Davis.
All right. Christina Davis, come on in.
Hello. Let me turn my camera on. It's not working. There you go. Hello.
Hello.
Hi. Thank you, Madam Chairman Wilson and Co-Chairman Scott and committee members for allowing me to speak. My name is Christina Davis and I'm a nurse practitioner. I practice as a sole provider in Sundance, Wyoming, which is a critical access facility. My colleagues have done well discussing why we are opposed to the APRN compact. On the surface, the compact looks promising. However, if this compact is put into law by Wyoming legislation, it will open a door of opportunity for organizations against full practice authority. Full practice authority is a cornerstone of our profession, and the revised APRN compact requires an APRN to have 2,080 hours of practice prior to being eligible to join the compact. This requirement will allow other organizations against full practice authority to question Wyoming's current law, which allows full practice authority upon licensure. This conflicts with our current Nurse Practice Act. And what ground will the Board of Nursing in the state have to stand to protect FPA, and while also requesting to join an APRN compact, which requires 1 year of service before the licensee can apply? Full practice authority is a mainstay to increased access to care. And since 2004, Wyoming has had full practice authority for nurse practitioners. FPA allows APRNs to practice to their fullest scope and educational training. And this gives Wyoming residents greater access to healthcare that otherwise would be lacking. Although we do like a compact, this revised compact wording is discoordinate, and the amended language is not conducive to our profession nationally and statewide, and is a general step backwards for Wyoming. I respectfully ask that the Labor Committee consider rejecting the amended APRN compact for the sake of maintaining full practice authority for Wyoming APRNs, which will ultimately provide increased access to care. We would rather have no compact than a compact that compromises what we stand for as a profession. Thank you for your time.
Thank you. Questions for Ms. Davis? I don't see any. Okay, who have we got next?
I believe our last individual is Mr. Eric Foley.
Okay, send him in. Am I missing him? Is he here?
Madam Chairman.
Oh, there you are, a black rectangle. I didn't recognize you at first.
I apologize. This virtual meeting, a pain somewhere. I won't tell you where.
All right,
Chairman,
Mr. Bowley.
Eric Bowley with Wyoming Hospital Association, and I won't belabor this point too much. I do want you to know from our perspective how important APRNs are to the work that we do in serving our state. Dr. Davis and I have spent a lot of time working on a lot of issues together when it comes to the APRNs. With that said, compacts are very important. And with COVID, we found out how important they really have been. The physician compact in particular has really increased our ability to care for those during this pandemic. And I'm glad that we had that in place as we entered the pandemic. The APRNs are a vital, important part of delivering healthcare, and access to care around our state is vital. I think a thoughtful approach, a compact, we've also always supported compacts. We continue to support those. We were the first ones that wanted to pass the nursing compact years ago. We're glad to see the compacts in place. And I think a compact that would help with APRNs being able to work across state lines at times such as these and in the future will only increase our ability to serve our patients And with that, I'd stand for any questions.
Questions for Mr. Bowley? Evidently not. Okay, I'm just going to circle back briefly to Ms. Labonte. We're certainly, as always, going over our scheduled time. Ms. Labonte, just briefly, and you don't need to repeat the whole thing, but if you have a couple of brief answers to any of the concerns expressed.
Yes, Chairman Wilson and Chairman Scott in the committee, thank you for this opportunity to close out. APRNs are integral to healthcare in Wyoming and across the nation, and we want them to continue. We prefer full practice authority. This compact that we're asking you to support does not preclude full practice authority in Wyoming, absolutely does not. And it's an option. An APRN can still have a single state license. Ms. Kidner had talked about an APRN advisory committee. This is a regulatory bill, not an association bill. So with that said, the association or the committee that handles APRN compacts, they're made up of the executive officers of the boards of nursing. And I can promise you that we are well supported by APRN colleagues in our states, and we get a lot of information from them. We have an APRN on staff, and we look to them for advice. So the commission, the APRN Compact Commission, is fully supported by APRNs, and many, Texas is an example, their EO is an APRN. So they would have a voice on the commission. I believe this compact is in the best interest of all parties. It is an accommodation. I get that part. I like the one we had. Unfortunately, I believe that we also need to compromise, and this was a compromise we hoped between states with transition to practice authority and full practice authority in an attempt to get a compact nation.
Okay, thanks very much. All right, Representative Barlow, question for Ms. Labonte?
Thank you, Madam Chairman. So there's 3 states that have the existing compact adopted. Seems to me that the simplest thing to do would be go in and change the number of states down to 3 states, initiate the compact, and then see who comes on the existing one. Any thoughts on that, Ms. Labonte?
Ms. Labonte?
Thank you again, Chairman Wilson and Scott and Representative Barlow. You know, that had been discussed as kind of run a trial. It didn't get anywhere with the other executive officers. It's not off the table. I'm still willing to do it. Unfortunately, we do have APRNs who aren't necessarily going to travel to Idaho or to North Dakota. So it has some limiting factors there, but it's a possibility.
Senator Pappas.
Yes, one thing of concern when you start getting to lower numbers of states, there is an administrative cost to running these organizations. These compacts will have commissions, and typically the costs for having a commission and the staff to run the commission are fixed costs. So if you want to spread them out over many states, then it gets less expensive for each state. And so to have 3 states, I see it pretty problematic.
Okay, final questions for Ms. Labonte. Right, then public testimony is closed. Senator Scott. You're muted.
Madam Chairman, as we look at how we're going to move forward on this, let me say first that I'm very much a supporter of the full practice ability that we've got now. I'm one of the legislators responsible for us taking advantage of an opportunity and getting that. And I'm proud of it because I think it was the right thing to do. So I have a lot of sympathy with the point of view we've been hearing, that we don't want to go backwards on that. But somehow we've got to work out a compromise that everybody can agree to. It sounds to me like we're not there yet. And I don't see any point in us at this point taking the LSO and the committee time necessary to put this bill into final form. Because frankly, with the degree of opposition we've heard today from the members in the organization in the profession, I doubt we can pass it. I think what we ought to do is hold this forward for a issue to discuss in a future interim, maybe next one, maybe 2 years from now, see if the profession can work out its differences amongst itself. And if they can't, what I would suggest is then the committee should work on a single state bill for Wyoming that would make it easier for APRNs from full practice states to get licensed here, expedite that, reduce the fee, and maybe have a dual structure where there's a minor fee if they'll grant us reciprocity and a larger fee if they won't, but we'll still be happy to take their nurses. Something along those lines until the profession can get its act together and decide what it really wants to do, which I perceive that it doesn't have right now, or we wouldn't get this degree of opposition. I think it needs a year or two to see if they can develop a consensus before we start looking at a single state solution, which would be basically designed to make it easier for us to raid nurses from other states. And maybe would encourage some reciprocity. But I just don't think this one is ready for prime time yet, Madam Chairman. And my recommendation to the committee is let this one sleep for a year.
Okay, is there anyone on the committee who wants to move the bill? I don't see any. So Ms. Labonte, the Labor Committee, I believe, is always supportive of nursing and of compacts, and we would, I am sure, enthusiastically put a revised compact on our agenda next year or in some fuller time. It certainly, when I heard about it at first, yeah, as you know, I said, yes, definitely we'll put it on the agenda. But it does sound a little bit like even if we got it passed, you might not actually have any nurses apply for the licenses. I don't know. So I regret to say thank you for your presentation, and we will look forward to updates as far as how things develop nationally with a future compact. Representative Barlow.
So, Madam Chairman, I just want to follow up with the discussion on the compact and the discussion from TAPIS about administrative costs, et cetera. If Ms. Labonte and some of her colleagues from those other 2 states could get some numbers and see what those impacts would be, I'm certainly more than willing to at least take a shot at changing that compact for a lower number of states threshold and see if we can initiate something with the full practice states that are already in existence. So I'm certainly willing to take that on as an individual effort, and but obviously there needs to be some substantiation, including the administrative cost element. Thank you, Madam Chairman.
Very good. You were a little blurred on your internet there, but I think private emails along the side will probably work fine. Okay, committee, we were scheduled to pick up 2 more bills now, but frankly, seeing as it's 12:40, and LSO really did want to have lunch. The rest of us legislators, of course, are sturdier and can survive on air alone, but we are going to recess for lunch, and we will be back at 1:45 to pick up the Mental Health Professions Practice Act bills and carry on from there. So we will recess until 1:45.
Ma'am, I will also like to mention for anybody who is watching the stream on YouTube, there will be a new PM stream. Zoom participants, you're still in the same meeting, but for anyone watching us live, there will be a different link this afternoon.
Okay, so members, please make sure to mute yourselves. You can turn off your picture, and if you come back early, please don't eat potato chips right in front of the camera or something. Thank you. See you in a while. Enjoy your lunch.